I see a Barry.
I see a Barry.
I'm here. Just hopped on.
Hey,
Hello.
Barry. Afternoon, everyone. We're just letting everyone in, so we'll get started in a minute or two. Thank you for joining us. Hey, Andy.
Yes, sir.
After you do the proclamation reading to Joe, I think it's appropriate to talk about the appointment.
Okay, perfect.
Okay.
Sounds good.
Are you good, Christina? Okay. Good afternoon, everyone. Chair's got 2 o'clock. Thank you very much for joining us for the September 29 PDAB board meeting, virtual. We have a quorum. We've established a quorum, so I'm going to call the meeting to order. And we have a couple changes on the agenda that I'll go through as we go through the meeting. The first one is on number 2 for the board members. We will be approving the July 28 minutes only, not the closed session. We'll take them up at probably the November meeting. So I know they were distributed. I hope you all had a chance to review. So I'll entertain a motion.
So moved.
Second.
Moved by Jerry, second by Stephen. All those in favor, aye.
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 Opposed, thank you. Item number 3 on our agenda is a proclamation to our longtime board member whose term was up, I guess, about a year and a half ago. Dr. Levy's appointment was the governor's appointment, and the governor's office has appointed someone. So they have sent Joe his letter last month, and the board prepared a proclamation that I'm going to have Andy read and that we are going to sign and mail to Joe. And hopefully all of y'all will have an opportunity to thank Joe for his time and I guess it was about 5 years that he served, Andy. Is that right? Yeah.
Full 5
About
years.
5 years, which is a long time for anyone to serve on a board. So, Andy?
Thank you, Mr. Chair. So this proclamation is for Dr. Joseph Levy, board member from November 15th, 2019 to August 13th, 2025. Whereas the prescription drug affordability recognizes that the commitment and expertise of its members is critical to fulfilling the board's mission. And whereas Dr. Joseph Levy is a respected member of the academic community and has consistently volunteered his time and expertise on behalf of the state of Maryland and its residents. And whereas Dr. Levy has leveraged his expertise in health economics to inform the board's rigorous analysis and study of the dynamics of the prescription drug market and drug pricing. Whereas Dr. Levy has routinely contributed to robust discussions and deliberations of the board, providing critical insights and perspective. Whereas Dr. Levy has brought creative thinking to this work and leveraged his formidable problem-solving skills to consider complex policy challenges. Whereas Dr. Levy has demonstrated high standards of professionalism and public service. And whereas Dr. Levy is a respected board member who will be missed by his colleagues. Now, therefore, be it resolved by the Prescription Drug Affordability Board that due acknowledgement be made of Dr. Levy's service and contributions to the board and gratitude be extended to him. And be it further resolved that this proclamation be transmitted to Dr. Joseph Levy.
Great. Thank you very much, Andy. We certainly will miss Joe, but we hopefully he will be available if we need him for anything in particular. And we again thank him on behalf of all Marylanders. We thank him for his time and his service that he gave for us. Andy, you want to briefly make an announcement before we put out the press release about the governor's appointment to the board, new member?
Yes, thank you. So the governor's office has issued a new appointment for Dr. Georges C. Benjamin, MD. He's a well-known health policy leader and practitioner and administrator. He currently serves as the executive director of the American Public Health Association, the nation's oldest and largest organization of public health professionals. And he's also a former health secretary of the state of Maryland, and also a graduate of the Illinois Institute of Technology and the University of Illinois College of Medicine. He's board certified in internal medicine, a master of the American College of Physicians, a fellow of the National Academy of Public Administration, a fellow emeritus of the American College of Emergency Physicians, and a member of the National Academy of Medicine. He's going to be a very strong addition to the board.
Great. Thank you very much, Andy. And just to add a couple things, I've known George's for over 30 years now, worked with him in 3 or 4 different capacities over that time. Very, very collegial, very supportive of groups that he's involved in. I'm actually surprised that he's got the time for this because he does a lot of traveling. Andy and staff are in the process of onboarding him over the next 30 days. He does have some commitments through the fall, so whether or not he will join us in person in November, we're not sure yet, but hopefully come December, January, he'll be fully engaged and on board. He is getting up to speed, like I said, so I hope all of you will send out his information to you, his email. Hopefully you'll just send him a short note, and you will welcome him when we are able to have him on board. Any questions about Dr. Benjamin? Okay, hearing none, that takes care of the first 3 items. Christina, item 4, public comment.
Yes, thank you, Chair Mitchell. The board received 5 written comments, which were shared with the board and posted to the website. We currently have 7 people registered to provide oral public comment today. Each commenter will have 1 minute and 30 seconds to speak. We have several county executives here today with us, so I will begin with them. Once I call on you, please state your name, the organization, agency, employer, or other entity with what you're affiliated, if any, or whether you're a consumer, and the agenda item that you would like to address, and then you can start your comment. I'm going to start with Howard County's County Executive, Calvin Ball. I thought I saw him join. Calvin Ball. Okay, we'll come back. The president of the Charles County Board of Commissioners, Mr. Reuben Collins, are you with us?
I'm with you. Can you hear me?
Yes, I can. Thank you.
Can you see me? Because I can't see myself. Oh,
Yes, we can see you.
okay.
Okay, I'm gonna start the timer and then you may begin.
And good afternoon, everyone. Marylanders can be proud that in 2019, we became the first state in the nation to create a prescription drug affordability board with the authority to make high-cost medicines more affordable. Since then, other states have followed our lead. I want to thank Chairman Mitchell, the board members, and your staff for the work you've done to study how rising drug prices are affecting all Marylanders, especially on the state and local level. In my county, these costs are straining our budget, and once upper payment limits are set, we will be able to save money that can protect services and ease the burden on our taxpayers. It's critically important that you act as soon as possible to set upper payment limits on what state and local governments pay for these medicines. We also urge you to move quickly on other high-cost drugs under review. We are so grateful to our governor and the General Assembly for expanding this authority so that beginning next year, we can help make medicines more affordable for every single Maryland resident. Medicines don't work if people can't afford them, and we're counting on you to keep Maryland a leader in this effort. Thank you.
Thank you. Thank you very much. Up next, we have Montgomery County Executive, Mark Elrick. Mr. Elrick, are you here with us today?
Yes, I am.
Great.
Thank you.
You may begin. Thank you.
So thank you, and Chairman Mitchell and the members of the Prescription Drug Affordability Board for all the important work that you're doing. Maryland led the nation in 2019 by creating the first board with authority to put upper payment limits on high-cost drugs. And I'm glad to see other states are following our lead. I know how urgent this is. I know it as a government leader. I also know it as a consumer. The costs of Jardiance and Farxiga are straining local government budgets, including ours in Montgomery County. As one of the largest local government employers in Maryland, we are working closely with the PDAB to implement these benefits for our own employees. Every dollar we save on these drugs is a dollar we can use to fund critical services or ease the burden on our taxpayers. That's why it's so important for you to move quickly to set upper payment limits. We also urge you to continue your work on other high-cost drugs like Ozempic, tirzepatide, which all pose similar affordability challenges. I want to recognize the collaboration with my fellow county leaders and with members of the General Assembly, as well as Governor Moore, whose leadership helped expand this authority so that eventually all Marylanders, not just government employees, will benefit. At the end of the day, drugs don't work if people can't afford them. I appreciate your commitment to making sure Maryland remains a national leader in tackling this crisis. Thank you.
Thank you. Thank you very much. Up next, we have Anne Arundel County Executive Stuart Pittman. Mr. Pittman.
All
are you
right,
here with us?
thank you. Yeah, I second everything that Ruben and Mark said. I don't think that I'll be as perfect in getting just to the 90 seconds, but I mostly want to say, because I haven't testified before in front of this this board, that I thank you for the work that you've done, and that we're all relying on you or watching you, and we're waiting eagerly to get these first two drugs upper payment limit set. I talk to folks around the country about this, and they often ask me how it is that we were able to convince the General Assembly to do this in 19 and then get it extended for private plans this last year. And I say, you know, it was largely that it was the consensus was there, and county leaders, bipartisan county leaders, Maryland Association of Counties, we really fought hard for this. And now we've got 3 other states that are in a race with us to see who can really move the fastest and get these upper payment limits set. When I look at the big picture of bringing down, creating affordability and making healthcare more affordable, really what we are doing in Maryland and what you are doing in this board is as important as anything going on. And I talked to the governor about this as well, that this should be something that we talk about in the state of Maryland and brag about. But we're depending on you to do the work, to do it right. I know that it's all going to be challenged. The pharmaceutical companies are not happy about some of this, but this is the only way we're going to bring down the cost. So thank you for the work you do.
Thank you. Mr. Calvin Ball, are you with us?
I sure am.
Great. Thank you. You can begin.
Well, good afternoon, Chair, and all the members of the Prescription Drug Affordability Board. First of all, I want to just thank you for your tireless efforts to remove those financial barriers to vital prescription drugs for people. This board plays an important role by recommending actions we should take to make drugs affordable for all of our residents, especially those who are the most vulnerable. And I am so grateful for the work that the board is doing here, because drugs don't work if people can't afford them. Maryland is a national leader when it comes to making prescription drugs affordable for residents. In fact, since 2019, when we became the first state to create a prescription drug affordability board, 3 other states have followed our lead. And it's unacceptable for Howard County residents or residents throughout the great state of Maryland to have to choose between paying for their prescription drugs or buying groceries. Our residents deserve better, and we have to do everything in our power to lower prescription drugs. 2 such drugs, Jardiance and Farxiga, are two popular diabetes drugs that many residents desperately need but can't afford. We must set an upper payment limit on what we can pay for these drugs so that we will be able to save money, which can be used to fund critical services and provide relief for our residents.
Thank
And we're very grateful to Governor Moore, the General Assembly, and everyone who's working so hard on this issue. Thank you.
Thank you. Thank you to our county executives today. Up next, we have Mr. Derek Flowers from the Value of Care Coalition. Mr. Flowers, are you with us today?
I am, Christina. Thank you.
You may begin.
Great. I'm Derek Flowers with the Value of Care Coalition. We're a network of patient, provider, and caregiver organizations. Today, the board faces difficult choices in its policy decisions for Farxiga and Jardiance. Based on the word of doctors, pharmacists, and health plans, one truth has become clear. Upper payment limits do not guarantee patient savings, but they do threaten patient access. Board member Dr. Anderson underscored this point with NBC News this summer, noting that PBMs, quote, are looking for the drug that makes them the most money. He explained the negotiation-based relationship between PBMs and manufacturers, insurance coverage and access. Manufacturers seek formulary placement, PBMs seek the biggest rebate. Rebates drive up list prices and in some cases, as you found in your reviews, patient costs. But if UPLs restrict that negotiation, lack of rebates could impact formulary status, reducing coverage. Pharmacists warn they may not even be able to stock a price cap drug. This is not affordability, it's diminished access and it has a negative impact on patient care. Similarly, we applaud the forward-looking voices on this board. Dr. Abiri rightly noted that benefit design is central to patient affordability. Benefit design issues like deductibles, co-insurance, tiering, and utilization management also dictate whether a patient can walk away from the pharmacy counter with their prescribed medicine. Without reform in these areas, patients will continue to face overnight cost spikes, prior authorization delays, and treatment denials, even if the list prices are capped. For these reasons, we urge the board to reject UPLs as a policy option and instead advance solutions that bring transparency to benefit design, address cost sharing at the counter, and ensure patients receive meaningful relief without sacrificing access. Thank you.
Thank you. Up next, we have Mr. George Huntley. Mr. Huntley, are you with us?
Yes, I am.
Okay. Can you speak the agency or organization that you're with and then the agenda item that you're addressing?
Yes, so I'm George Huntley. I'm the CEO of the Diabetes Patient Advocacy Coalition. And again, thank you for the opportunity to speak on behalf of patients living with diabetes.
Okay. Thank you. You may begin.
Okay. Again, thank you for the opportunity, Mr. Chair, members of the committee, to provide public comment on the cost of Jardiance and Farxiga. As the board continues its policy review process, we urge you again to ensure that efforts to contain costs do not come at the expense of patient access to these essential diabetes treatments. Maryland's planned UPL framework remains rebate-driven, relying on supplemental rebates from manufacturers. As Mr. York noted during the recent informational hearing, the board's plan is to layer additional rebates on top of existing flows. However, it is unclear how such a requirement would actually function across the state's diverse coverage landscape, which includes state employee plans, ACA marketplace plans, and commercial plans, each plan contracting with different PBMs under different terms and conditions. This is where the real risk to patients lies. Carriers and PBMs control how drugs are covered, and their incentives are tied to rebates, not patient affordability. Changing rebate flows without protecting patients could easily create unintended consequences such as formulary exclusions and tier manipulation. Tier manipulation where they put this now lower priced drug on a higher copay tier to disincentivize patients from actually taking it. In addition, it could be anticipated that some will see stricter prior authorization hurdles, even at the dosage change level. And you have, as you just heard, pharmacists that may not be able to actually stock the drug. That's why the board should focus on non-UPL solutions, directly reducing patient costs while preserving access, point-of-sale rebates, delinking PBM compensation, and out-of-pocket protections for Marylanders so they can afford their medications predictably. Thank you.
Thank you. And then lastly, we have Tiffany Westridge Robertson. Are you with us today?
I am.
Great. Would you like to state the agency, organization, or other entity in which you're affiliated with, and then the agenda item that you are addressing, and then you may begin.
Sure, thank you. I'm speaking on behalf of Ensuring Access Through Collaborative Health, or EACH, and the Coordinating Patient Inclusion Council, which is PIC. coalition addressing government drug affordability reviews to ensure that patients are front and center. And it's going to comment on the policy review process and recommendations.
You may begin.
All right, thank you so much for the opportunity. In economic reviews, it's important to recognize when costs reflect clinical value. The drugs under review show added value because of additional research that demonstrates they significantly reduce the risk of heart failure, kidney disease in patients with type 2 diabetes. These aren't interchangeable options. They're guideline recommended, and even the dossiers acknowledge there are no true therapeutic equivalents, all equating a high value ranking. Yet reviews were dominated by comparisons to drugs with different mechanisms of action and price points, suggesting interchangeability is acceptable and in turn negates scientific and patient-reported demonstrated value. Patients overwhelmingly report affordability challenges based on insurance design and cumulative costs. They pay $0 for the same drug on one plan, they switch a plan, and now it's $300. So a UPL cannot fix that, and respectfully, they also won't help out-of-pocket costs for Marylanders. That's why UPL, non-UPL reforms are essential. I won't repeat what George just eloquently said, all of the points that he just mentioned. Lastly, in the informational hearing, we heard that the PDAB has supplemental rebate structure solution to address the concerns directed to the UPL action plan. To learn more, unfortunately, I found nothing there and respectfully request the board solution to share in detail more details so that we can weigh in and patient voices are heard in the outcomes. Thank you again for the opportunity to focus on reforms that truly make sure that drugs are affordable to Marylanders. Thank you.
Thank you. That concludes the public comment for today.
Great, thank you very much. Thanks, Christina. Thanks to all the folks that participated and to our county execs for taking out time out of their busy schedules because they have counties to run. Next, that'll take us to item number 5, policy review process. Andy?
Great, thanks, Chair Mitchell. The meat of today's meeting is going to be walking through a presentation from staff on the preliminary policy recommendations. So Christine, if you go to the next slide, we're going to give a quick summary, and I promise to keep that very quick, of just where we are in the cost review study process and just go over your preliminary determinations. We'll talk about the policy review process, which is where we are now in the process. I'm going to summarize the information that we received from our information gathering step. So that's the information that staff used to inform our policy recommendations. And the presentation is going to end with a series of policy recommendations for the 2 drugs that we are kind of at this step in the process. Next slide, Christina. All right, so as board members already know, and for the public's information, in the July 28th meeting, the board had the opportunity to examine this is the statutory requirement of the board, whether or not the use of each drug, Jardiance and Farxiga, has led or will lead to affordability challenges to the state healthcare system or high out-of-pocket costs for patients, and whether that use has led to affordability challenges or high out-of-pocket costs is consistent with labeling approved by the FDA or standard medical practice. And the board identified circumstances under which the prescription drug has led or will lead to an affordability challenge for the state healthcare system or high out-of-pocket costs for patients. So again, this is based on our statute. Next slide. In that meeting, the board made 3 or 4 preliminary determinations, and these identify the circumstances under which the prescription drug products have led to affordability challenges. The first one was that the percentage change in wholesale acquisition costs, or the list price over time, is substantially larger than the percentage change in inflation. The second one was that, and this was for both drugs, at the 90th percentile, patient out-of-pocket costs in certain markets was disproportionate to the net cost paid by payers, and that's again for both drugs. And then for each drug, the total gross spending for Farxiga for the state and local government exceeds 1% of gross prescription drug spend for the state and local government. And then for Jardiance, the total gross spending for Jardiance for state and local government exceeded 1.8% of the gross prescription drug spend for the state. So I'll go over these again as we go back into the drivers, but these were the determinations that were the preliminary determinations that were made by the board and kind of set off the rest of this process. Next slide. So the next steps after this preliminary determination is to draft our draft report. So staff is currently drafting and preparing a draft of the preliminary determination on the cost review report that summarizes the information considered by the board in conducting the cost review study, the board's deliberations, the circumstances or indices reflecting the affordability challenge, and the board's preliminary determination. We are going to post this document for public comment. We always need to make the stipulation that this preliminary determination is a non-final and is subject to revision or modification. So the public can expect us to publish this draft of the report in the foreseeable future. Next slide. So the purpose of the policy review process, and it's just based on the regs, is to based on the best available information, confirm the drivers and market conditions causing the affordability challenge, and then identify the policies that may address those drivers and redress the affordability challenges. So that's kind of what we're walking through today. The circumstances are the what, the drivers are kind of the why or what caused those circumstances, and then our policy recommendations are supposed to tie directly to those drivers and hopefully address the circumstances that we found. Christine, if you go to the next slide. You've seen this graphic before. I'm going to keep it very quick, but once we are in the preliminary policy process, we have a few different tracks that are running. That bottom track on the red is that draft report that I just mentioned. So we're going to publish a draft determination report. We're going to have public comments. We're going to update the report. And the final step is for the board to approve the report. The middle is the blue, which is for our non-UPL policy recommendations. We do have a series of those in this presentation. So this is the process here. And then green, if the board recommends moving forward with upper payment limits, we have a separate process specific to the upper payment limits. All of these they end at the same time. The first thing that needs to happen is the board needs to finalize their report. And then at that point, you can take final action on both non-UPL policies and the UPL policy. Next slide. So going through the policy review process, again, that's what we're doing today. There's a few key points. One is information gathering to gather the information that staff needs to make our recommendations. Then is the preliminary policy recommendations, which is our presentation today. That's on non-UPL policies and a UPL policy in the process for setting up our payment limits. And then finally is the final actions. So all three of those processes on the slide above can end at the same time. Next slide. The board has 5 tools in our regulations that allow us for information gathering. So again, this is to gather additional information that wasn't necessarily available from the cost review study up to this point, i.e. the dossier, and answer questions, kind of open questions that we need to identify the policies that can make to address the different challenges that the board identified. First is informational hearings, and we'll go through each of these individually. The second is stakeholder council input. We also have a tool, a very specific tool for expert testimony hearings. We have not used that tool for this section of the cost review or this cost review study yet, though it's still on the table if we need it. Also, board staff can do research and analyses, and then finally, the board and board staff can request data from eligible governmental entities. So I'll just provide an update and summary of each of the different things that we did for the information gathering. Next slide. So the board staff were able to conduct two separate sessions of an informational gathering or an informational hearing. The board may, through board staff, convene a hearing to receive input, information, and opinions from the public and stakeholder to inform the consideration and development of policy options, including upper payment limits, to redress an affordability challenge. And those are the regulations that articulate the findings. Next slide, Christina. So the hearings were held on September 3rd. One was at 1 p.m. and one was at 6 p.m. In the 1 p.m. hearing, and just these exhibits end the board has received the exhibits and a record of the meeting, but I am going to summarize the meeting for the purposes of the board's information today. So in our 1 p.m. hearing, we had 4 folks that registered, and we received 9 different exhibits. Exhibits 3 through 9 were written comments submitted in lieu of testifying. And for the 1 p.m. Hearing, we had Reverend Dr. Sandra Connor, representing the president of Baptist Ministers United Conference in Baltimore and vicinity, And she basically highlighted the struggles of senior citizens and others with high-cost prescription drugs, particularly Jardiance. And she emphasized the need for patient feedback, user-friendly information, and increased outreach to address affordability challenges. So really making sure that we're engaging the patients that we need to, that we're trying to serve. Our next speaker was Len Lucci, an attorney in Annapolis and patient living with diabetes, and he shared personal experiences and stories that were told to him about other patients that were unable to afford their medications. He expressed concerns about spending on pharmaceutical advertising over efforts to lower prescription drugs and praised consideration of upper payment limits. We had Mr. George Huntley, the CEO of Diabetes Patient Advocacy Coalition and patient living with type 1 diabetes. And he emphasized the life-changing nature of these two drugs, Jardiance and Farxiga, and then the negative health outcomes that could come from a lack of access. As you heard in his testimony or his public comment today as well, spent a lot of time going into detail on how certain incentives in the pharmacy benefit manager space can contribute to high costs, especially around rebate incentives. And then also made specific recommendations around delinking PBM, PBM reimbursement from rebates, and then also flagged a prescription drug assistance model that you will see later in this presentation. So did suggest a number of different potential policies outside of UPLs that could help patients, and did express concerns about UPLs that were echoed in his comments earlier today. Finally, we had Rainier Simons, a Community Access National Network patient advocacy group, who flagged that a lot of the challenges that patients are having is often related to plan design issues, specifically high deductible plans and plans with coinsurance rates, and suggested working with CMS coordinators and our health benefit exchange to set different kinds of benchmarks for acceptable plans. So talked about some plan design opportunities that we could have. And then also cited research indicating potential adverse effects of UPLs on formularies, such as moving drugs to higher tiers and increasing patient costs. Next slide, Christina. In our 6 p.m. Hearing, we had one person register, Ms. Tiffany Westrich Robinson, who is affiliated with the Ensuring Access Through Collaborative Health and Coordinating Patient Inclusion Council, EACH and PIC coalitions. She provided 2 exhibits of studies that she's a survey that her coalition has developed that tries to more directly assess patients' experience with trying to afford drugs. She emphasized that prioritizing patient needs and affordability policies and understanding the why behind their challenges is key to identifying effective policies. And then she did present the pilot survey findings showing that affordability is kind of a lived experience and can vary by patient and is often based on insurance barriers and changes, not necessarily just the cost of the drug itself. She, again, raised concerns that UPLs may not benefit patients and could lead to unintended consequences, such as PBMs preferring other drugs. She did mention some other potential non-UPL policies, such as capping patient out-of-pocket costs and better regulations of PBMs. So that was our informational hearing. Again, the informational hearings do provide this more of an unstructured opportunity to get feedback. You'll see that some of the names are familiar from some of the public comment that you've received, but it does kind of open up the forum and allow for broader kind of question and answer and deeper dives on specific issues that the public are flagging. So very much appreciate the participants of our informational hearings, and this was very valuable information for board and board staff. Next slide, Christina. The next item is the next tool for information gathering is stakeholder council input. So the board may request input from the stakeholder council, and this input can be a request for general input and ideas on policies, or more specific requests for specific information. And the board staff may provide that in summaries of inputs from the stakeholder council. So this presentation will serve as that summary. The board staff did provide a series of potential items that the stakeholder council can provide feedback on. The stakeholder count, you can go to the next slide, Christina, thanks. The Stakeholder Council received public comments from the Diabetes Advocacy Coalition, Each Fit Coalition, and the Value of Care Coalition. We also did receive one letter that came in after the deadline, but all four of those letters are posted on the website and have been made available to the board. Next slide. We also had some folks speak, and this is just a summary of the comments that they received. So the public comments that the Stakeholder Council received were from George Huntley and Tiffany Westrich Robinson. You can see here that they largely aligned with the comments that were just submitted to the board. But basically, again, essential therapies, Mr. Huntley also recommended against UPLs, but did flag other tools that may be available, recommended patient-focused non-UPL solutions, and then also, again, commented on PBM design and payer design to try to pull some emphasis off of rebates. And then also, again, recommended the delinking of PBM reimbursement from drug prices. Ms. Westrich Robinson urged the PDAB and the PDASC to evaluate all policy options, and then referenced her report. She presented the findings from her survey and her report. All right, so Christina, if you move to the next slide. So the way we tried to organize the summary is just tying each of the comments to circumstances, and we tried to summarize the different feedback that different Stakeholder Council members provided. For our circumstance one, the percentage change in WAC in list price over time is substantially larger than the percentage change in inflation. Mr. Darren Johnson of the brand names corporations, Mr. Sean Brown of the generic drug corporations, and Dr. John Gambrell, who's our public member, flagged that benefit design by insurers and market dynamics of PBMs is probably one of the major issues driving the WAC increases. So PBMs demand higher rebates for formulary replacement and then promise manufacturers to raise their list prices to meet those PBM demands. They did also flag the delinking of PBM reimbursement to rebates, and then also mentioned passing rebates directly to patients through point of sale discounts. Dr. Sean Tunis, our health services researcher specializing in prescription drugs, and Mr. Glenn Schneider, Statewide Health Advocacy Coalition, mentioned that the UBL creates an environment where currently unaffected manufacturers anticipate its impact and can adjust their pricing strategies accordingly. So other entities can respond with the initial price set. So they mentioned that this tool has been successfully, or a flavor of this tool has been successfully implemented in other countries. And then Dr. Danita Tolson, the statewide organization for dose communities, had flagged the idea of establishing an inflation penalty on drug companies to add to existing penalties. Next slide. For circumstance two, so this is at the 90th percentile. Patient out-of-pocket costs in certain markets is disproportionate to the net cost paid by payers. Mr. Johnson of the brand name drug corporations and Dr. Hill Golden of the clinical researchers flagged that one driver is insurers using accumulator programs and benefit designs that shift the cost onto the patients. Some of those policy solutions are to support the recently passed legislation to end the practice by ensuring that all payments count towards patients' deductibles and changing the plan design to offer first dollar coverage. And then Mr. Johnson also flagged that the industry would support a deductible smoothing policy. And I'll talk about that a little bit later. Next slide. For circumstances 3 and 4, the total gross spending of Farxiga for state and local government exceeds 1% of total prescription drug spend for state and local government and 1.8% for Jardiance. Dr. Sean Tunis and Dr. Hill, and I think also Mr. Johnson referred that these drivers are, one of the drivers for this is that basically there's very high utilization. These are effective drugs that are recommended in clinical practice guidelines, and there is a high prevalence of diabetes in Maryland, and these drugs are especially useful for certain comorbidities. So, you know, it naturally has a high utilization and a moderate cost that can cause that gross spend to be high. So that was the, oh, and then we did have, if you go to the last slide, Christina, or 2 more slides, we have additional just general comments unrelated to the circumstances. Dr. Golden of the clinical researchers and Mr. Darren Johnson of the branding corporations continued to flag that the primary driver is insurance benefit design. So that's what's impacting patients' out-of-pocket costs. And they referenced the Each Pick survey where 100% cited insurance barriers and 3/4 skip doses due to insurance delays. Mr. Snyder of the Statewide Healthcare Coalition and Ms. Kimberly Robinson of the Pharmacy Benefit Managers flagged that drug costs originate with the manufacturer and ultimately impact all entities acquiring the drug throughout the supply chain. And then if you go to the last slide, Christina, Mr. Gutman, who was a public member, Mr. Snyder, the Statewide Health Advocacy Coalition, Dr. Tunis, the Health Services Research specializing in prescription drugs, and Dr. Tolson, Statewide Organization for Diverse Communities, flagged that the board needs to consider the time to develop alternative policies compared to UPLs, highlighting that this is an urgent issue that the board needs to take action on. Dr. Tunis also flagged that UPLs are not yet implemented and there's no evidence for unintended consequences, and flagged why Maryland's negative outcomes would differ from national trends if these factors were taken into account by the Medicare drug price negotiations, i.e. if we were able to do it for Medicare, why can't we do it for Maryland? Mr. Sean Brown flagged that the generic industry faces fixed PBM contracts that block price increases despite rising costs, contributing to shortages. So this flagged some kind of opposing data, and then flagged that the IRA creates long-term uncertainty for generics entering in 8 to 10 years, discouraging competition, which is more effective than price controls and lowering drug prices. And then Dr. Hill Golden and Mr. Johnson flagged that a clear and consistent definition of affordability is needed. So this is the summary of the stakeholder council input. So this was an important tool, and again, very much appreciate and thank the stakeholder council for all the valuable input that they've provided. I'll briefly summarize the last 2 data points, and then we'll kind of open it up for general discussion as we dive into the staff's policy recommendations. Next slide. Okay, so the board can do staff research and analysis. So board staff may provide the board with policy and research analyses related to the drivers of potential affordability challenges. You can go to the next slide, Christina. To do this, the staff has conducted a literature review and review of policies proposed or implemented by other entities or jurisdictions. And the current literature and policy reviews include 11 federal and state policies, including policies from CMS, Kentucky, and other states. And then we've reviewed 21 papers published in academic journals. Next slide. And then the last input for information gathering is information from eligible governmental entities. So the staff can collect information concerning prescription drug products and therapeutic alternatives from eligible governmental entities. We can collect information around utilization, spending, costs, plan design, formulary placement, rebates, discounts, price concessions, and other relevant information. And Christina, if you go to that last slide, we've requested this information from select governmental entities, and we're in the process of requesting that information from other governmental entities. A lot of this information is primarily confirmational. So we'll probably just inform the work that we've already done. And then eligible governmental entities are currently working to respond. And one thing that we found, if you go through the, we're not going to go back, but a lot of the data that we should ask for is often not even available to the eligible governmental entities. What I think is kind of a key finding of this work, that despite us having all of this authority to gather additional information, there are still a lot of unanswered questions and often, some gaps in what's available to us. Next slide. All right, so that's the information gathering, and I did just want to summarize everything just to get that into the record. Now I think we can dive into the meat of the discussion for the board members. Does anyone have any questions on the information gathering that we completed, or any questions on anything you saw up to this point?
So Andy, this is Jerry Anderson. I don't have any questions, but I just wanted to thank everybody who's provided such great information to us. The Stakeholder Council, all the people that have written comments in, oral comments in. This is a very complex issue, and getting all this different input is so important. So I really appreciate everybody taking a look at it from a variety of different perspectives. And I've had a chance to look through all of it, I can assure you. And I really, again, appreciate how hard everybody is working on behalf of the PDAB.
Great. Thank you, Dr. Anderson. And I would just say, hopefully, based on the work that you see in this presentation and the recommendations from staff, folks see that this information was very carefully considered and incorporated whenever appropriate. So again, just echoing Dr. Anderson's thanks to the public.
Andy, one comment from me, also echoing Jerry's comments here in terms of the time consideration everyone's put into this in responding, providing information when available. One clarifying question for me would be for the informational hearings. Could you remind me, how were those advertised, put out in front of the public? Could you just talk me through that process briefly?
Yeah, and I may invite the staff to correct me if anything, if I say anything incorrectly. But we published the notice on our website, I think 2 weeks in advance, and then we also pushed a notification out to our listserv with this notice. And the notice for the informational hearing had a series of questions where staff was trying to gather specific information for the board members. So that was all published on our websites and pushed out to all the communication channels that we have available to us.
Thank you.
Yep. Great. All right, so we will dive into the meat of the presentation. I do think it's probably okay, though I defer to the chair, for board members to ask questions along the way. Mr. Chair, do you have a preference on if board members ask questions along the way or save them for like section ends? I think it's okay for folks to to ask along the way, unless you might be on mute, sorry.
I think we've always preferred to have it done by section, like at the end of the section.
Okay.
Rather than interrupting you on each page. So
okay, that sounds good.
Why don't you pause at the end at a place where it makes sense for you to pause?
That makes sense. Okay, so I'm going to go through the drivers first. So I'll go through, okay, we'll go through the drivers, and then after each policy, there's a series of probably about 4 slides for each policy, and I'll just open it up for each policy after that. So, all right, so diving in, Christine, if you go to the next slide. So our regulations say that when we are recommending policy options for both UPL and non-UPL, staff may analyze the drivers of the affordability challenge, how the policy addresses the driver, the strengths and weaknesses of each policy, potential possible implementation of the policy through legislation, regulation, or enforcement, and then finally the potential impacts of the policy. And then specifically when evaluating the UPL, we can consider the relevant regulatory criteria in section 2 of the chapter. So we'll go through those in the slides. And then also the use of the drug by eligible governmental entities. Next slide. So that's the framework that we try to use when we're going through each of these policy options. Just as a refresher, here are circumstances. So just in terms of shorthand, the first circumstance is WAC increase over inflation. So that's kind of how I'll reference it. The second one is patient out-of-pocket costs is disproportionate to the net cost of the drug. That's kind of the shorthand that I will use for it. And then the last one is high total gross spending. And I'll use that for both 3 and 4. That's just going to be my shorthand when talking about when mapping back to the drivers. Next slide. So we have 2 drivers for circumstance 1. And again, that's WAC increase above inflation. The drivers that the staff incentivize, so again, the drivers are functionally the why. So the circumstance is what the board observed. Oh, actually, I guess, Christina, do you mind going back to the slide? I think one thing that's important to do as part of the circumstances is just also articulate exactly why these circumstances are important, i.e. do they harm patients? Do they harm the healthcare system? Why did the board identify these circumstances? So this kind of maps to the drivers in just a moment. So if there's a high WAC increase or high list increase over time, a percentage of often patient out-of-pocket costs are derived from that list price. So if the list price is increasing quickly, that can harm patients by increasing their out-of-pocket costs. So that's ultimately one of the reasons that the board identified this as a circumstance. The second one is pretty self-explanatory. If the patient is paying more out-of-pocket than what the plan design says they are, then that is harming the patient, right? If the patient is supposed to be paying 20% of coinsurance, But that actually turns out to be 50% of the net cost of the drug. They're actually paying more than what their plan design has advertised to them. And then the last one, total gross spend, it's very similar to the first circumstance in that it harms the public sector budgets, right? There's a heavy outlay on the public sector budget. And then also, again, patient out-of-pocket costs are often based on or derived from the list price of the gross spend. So that's how it can harm patients. So I did just want to like put that out there. The reason these circumstances are important is because they are harming patients in the healthcare system. All right, next slide, Christina. All right, so again, we have two drivers that are related to the first circumstance. First, the staff stated that the current incentives to maximize rebates instead of minimizing costs is one of the drivers that increases list price or WAC. So basically, for the public and for board members, manufacturers and PBMs negotiate their discounts through something called rebates that are off the books and often unknown to almost all parties except for the manufacturers and the PBM. Sometimes the PBM compensation can be based on that rebate. So the discount that they get, PBMs are often paid a percentage or a chunk or some sort of derivative of the discounts that they're able to negotiate. So PBMs very much like being able to negotiate higher rebates. What we see in this market, so because PBMs are paid a portion of those rebates, PBMs have a financial incentive to prefer their drug with a larger rebate over the drug with the lowest net cost. The increase in the list price allows rebates to increase without lowering the net cost. So again, PBMs have an incentive to get higher rebates. Manufacturers can increase those rebates by increasing the net cost or the list price without increasing the net cost. And then finally, because of the market power that manufacturers have, so market power is basically a company's ability to influence the market price and output by controlling supply, demand, or both, rather than being a price taker in a competitive market. So basically, this allows firms to set prices above its marginal cost that can be enhanced by outside factors. So like basically direct competition doesn't work. They're not competing on price, they're competing on other factors. In the case of prescription drugs, that's often based on a state-granted government monopoly or government-granted monopoly. But basically what's happening here is instead of reducing their costs to increase the rebates, manufacturers are simply increasing the list price. So that's what's happening here. That's the driver that we see happening. Next slide. The second driver that we see an increase in the WAC is that a higher list price or WAC gives the manufacturers more leverage in negotiation. In other words, when the prices are higher, the stakes are higher for an insurer to come to an agreement with the manufacturer. There's more pressure for the plan to provide coverage on that drug because the harm to the patient if they don't come to an agreement is higher. So basically increasing list prices puts pressure on the insurer to negotiate with the manufacturer, face increased costs to insurers and patients, and then also increasing the list price maximizes manufacturer profits, irrespective of whether the manufacturer has negotiated a rebate with the insurer, i.e. they're either getting paid a lot more because the list price is high, or they have a discount, but the discount is negotiated off of this higher list price. Next slide. For driver two, so that's the patients paying a disproportionate share of the net cost of the drug. We identified 3 different types of drivers, and basically what the finding was is that at the 90th percentile, so again, if you just line up all patients that are taking the drug at the 90th percentile, a disproportionate number of patients are paying a disproportionate share of the net cost of the drug. And we basically identified 3 types of patients that kind of fit in that bucket, or 3 ways to describe those patients. One is patients with that are basically using non-preferred drugs. So patients with high out-of-pocket costs are using drugs for which their health plans get lower rebates than average, and thus are non-preferred. So many insurance companies place drugs for which they have not reached an advantageous rebate agreement on a higher formulary tier. This often has the effect of incentivizing patients to use the preferred drug costs, and for a variety of reasons, some patients may prefer to use the higher price drug, i.e. the non-preferred drug. And as a result, a portion of that 90th percentile of out-of-pocket costs reflects patients that are using the drug that is expensive for them and the insurer, i.e. the non-preferred drug. Driver 2, if you go to the next slide, Christina, or the next kind of bucket of those patients is patients that are enrolled in high deductible health plans. So high deductible health plans are plans in which the patient must first pay their deductible or out-of-pocket costs before the plan begins to pay. In a high deductible health plan, the insurer PBM receives the rebates when a patient's paying the full cost of the drug in the deductible phase. Thus, irrespective of who pays, the insurer PBM receives the benefit of the rebate and not the patient. So just as a quick example, so if you are in your deductible phase and you have $1,000 deductible, the patient is paying all of the cost of the drug, even though the insurer and PBM are still getting a rebate. So the patient's actually paying more out of pocket than the payer has paid for that drug, if that makes sense. The last type, so if you go to 2.3, Christina, next slide, is patients that have higher out-of-pocket costs that represent for plans that have high coinsurance rates. So certain plans have high coinsurance rates for certain drugs. Usually, this is very common in like the specialty tiers, and a lot of the drugs that the board is looking at kind of fall within that specialty space. And coinsurance is often based on the list price or the WAC of the drug. So a relatively low percentage of coinsurance can cause a high out-of-pocket cost, right? If the list price of the drug is $1,000, you're paying 20%. You're paying $200, even though it's 20% of the drug. And again, we've already talked about how the net cost of the drug is actually often much lower based on after rebate amounts. So then that $200 could actually be up to 50%, just throwing out a hypothetical, rather than the 20% that their co-insurance said. They're actually paying 50% of what the cost to the plan was for that drug. Okay, and then Christine, if you go to the last one for circumstances 3 and 4, the driver that we identified was that gross spending is high on these drugs because they have high utilization. So these drugs have a special place in therapy for treating patients with comorbidities, which represents a large portion of the patients with diabetes. So gross spend, just by definition, is going to be high because there's a large number of patients, i.e. high utilization, and the drug has a high price, i.e. high cost. So those, if you go to the next slide, Christina, those are the drivers that the staff has identified that are the whys of the circumstances the board identified. Happy to talk through each of these. The rest of this presentation is going to be mapping specific policies to those drivers. So I do want to make sure that everyone understands what we're trying to say with those drivers, the why or the market circumstances that cause the circumstances that the board identified. So with that, I'll open it up for any comments or questions from the board.
So Andy, this is Jerry Anderson again. The first thing, and I think you said it, but I think it's very important for everybody to hear it again, is how high WAC prices or list prices often determine the out-of-pocket amount that somebody has to pay. So when list prices go up, the out-of-pocket cost that a person pays is often increased quite dramatically. And I think you articulated sort of why with the PBM dance with the industry, pharmaceutical industry, you hear it, but you got to recognize that the person or the entity that's increasing the price is the drug company themselves. I can understand why they're doing it, but they're the ones that are increasing the price. The other thing that we talk about is the fact that it's 1% for one of these drugs and 1.8% of the total spend for another drug. And these are drugs which are, in fact, very important, but they're also very expensive. And as what we're going to see in a moment is, they represent a significant number of patients, but not a huge number of patients. And so a lot of it is due to the fact that these are very expensive drugs, even though a number of people are using them. So, drivers 3 and 4 to me do make a difference because it's both the quantity and the price, but a lot of it is the price.
So Jerry, when you make that comment, are you only talking about, with those numbers, are you only looking at state employees and retirees?
Yes, we're going to see those numbers in a few minutes.
Okay, I just want to make
but Jerry, if I can make a quick comment, diabetes is a major health problem, in the state and across the country. And so there are going to be a lot of people taking diabetes drugs. And yes, these drugs are expensive, but there are a lot of people taking them. And it's the combination of those things that makes the hit to the state payer system and subsequently to the patients who have to who have to pay, their out-of-pocket costs.
I totally agree with you, Stephen, but if you think of some other drugs like statins, lots of people use them, but the total cost for statins is very small because the price of statins is very low. So it is a combination of both things, and we see this as Van suggested in the data that's coming up. But it's both price and quantity of that, and that's part of the reason why when we chose these drugs, we took a look at both the price and the quantity because we wanted to look at drugs which were expensive to the state.
Right.
Great, very helpful. So we are going to map back to each of these drivers. If the board can think of additional drivers, even as we're discussing, if you think the staff missed any drivers, please flag them for us. But these are the kind of the market conditions or reasons that these circumstances we think exist in the space, and these are the problems that we're basically trying to solve with our policy solutions. All right. So with that, I'm going to dive into the policy solutions. So one thing I just wanted to start with so we're going to start with the policy actions other than UPLs. We are going to save any discussion around UPLs for after these policy discussions. And I think it's worth noting that the authority for a lot of these policies is with other entities. Some of it may require legislation, so the board obviously doesn't pass legislation, and then even regulatory authority can fall within different agencies. So our partner agencies at the Department of Health or the Insurance Administration, there may be other agencies that actually would be the ones responsible for implementing the policies. So a lot of these would be recommendations from the board that obviously would carry a lot of weight, but would ultimately require partnership and implementation with other state entities.
But these recommendations or these other recommendations can be whether we move forward with UPL or not.
Sure. The second part, yes. Yeah, I almost like broke the conversation into two different parts. Right. So when we talk about the UPL, it is, I can explain what the next step in the process would be. So for each of these, the next step in the process would ultimately be, staff can flesh out some additional issues, but and we can do some additional information gathering. But the final step is a resolution from the board recommending these policies, and then we kind of take that and then go to the folks who would actually implement. So one of the resolutions could say that the staff recommends legislation, implementing a WAC inflation penalty, and there's additional work that needs to go into the actual implementation of that, but it's kind of handing the baton off, saying that the board has done the research and endorses those. Yeah.
Andy, can I ask you how that, so just to understand all the decision choices on the table for us. So we have these policy action options that are in front of us for an up-down vote, and do we move forward on them or not? Do we feel that we have enough information to move forward to recommend? What about for the UPLs? Is it a similar decision, which is, do we feel we have enough information in front of us to recommend?
Yes, and thank you for clarifying. I think that actually might be what Chair Mitchell was also asking. I think you're asking it in another way that clarified it for me, so thank you. Our final request is going to be guidance or direction from the board concerning which, if any, of the policies identified in the presentation should be further developed for the board's consideration. I.e., we have a very limited set of resources, so we are asking how we should be using our limited resources to promote additional policies or do the additional development necessary for policy to implement these policies. So it is kind of a yes, I would like to move forward with these. I think the no vote is going to be the most important, telling us just to stop wasting time and resources on certain topics if the board won't vote on it. But we can continue to develop policies, but at any point the board can kind of say no later in the process, right? If you feel like you need more information or it's underdeveloped, you can advise us to continue to develop it. It's not a waste of our time to do so, but that doesn't mean that for the final vote and the final policy determination, you are voting yes on it. We can go through this process, and then the final step can be you saying, no, we don't recommend it based on the information we have at that time. I'm not sure if that clarified for you.
If you're okay for me to rephrase, just so I'm sure I understand. So what's in front of us is an opportunity to make a recommendation for further consideration on all 5, right? Because there's 4 here, and then there's the UPL. and there's no recommendation for implementation, right? On the
Correct.
table today, it's a
Correct. I
recommendation
think
for further consideration.
what we would ask for, and I'll defer to the board on how, or board chair on how he would like to structure the vote, but I think we probably want to separate non-UPL. So I think we want to have a conversation about UPLs. You don't necessarily need to give this guide. You can do all the guidance at the end, but which non-UPL policies would you like us to continue to develop and ultimately probably bring to you in an upcoming meeting for an up-down vote on whether or not you recommend kind of endorsing the policy through a resolution? And then the second part of the discussion, which we haven't gotten to yet, is related to the upper payment limits. And I think what we would be asking for is, do you want us to continue through this process? And I'll go through what the next steps are. But do you have enough information here to say that a UPL is not the right policy solution? Or would you like us to kind of continue to get information, continue the next step and bring that to you? And I think at any step in this process, you can determine that it's, a UPL is, but the UPL, you haven't formally endorsed the UPL until the final step. Yeah.
Okay, I just want to be clear on when implementation is the choice in front of us. Because until now, I hear next step, further consideration, and I just want to be sure that we are deciding on something that's clear to us versus deciding on implementation and we didn't realize it, because I think that would not be ideal.
I think I understand. Go ahead.
Truth, part of this is, our last staff conversation, Barry, and in a regular weekly meeting that we have. And, I've been very somewhat impatient about the other items. I mean, I think everyone, there's a group of people that think UPLs are the only thing and the everything that we have in the toolbox. And I have constantly for the last 2 or 3 years brought up other things and talked about other things. So I like the fact that we're trying to separate these. I want to get some of these other things on the table because, as you know, some of them are legislative related and some of them could be policy through the governor or other state entities, whether it's Maryland Department of Health or the insurance commissioner or whatever. So I just want to make sure that whether it's 340B or other scenarios that are out there, that we're moving forward with not just UPL, for example, if that makes sense.
I would agree. Thanks, Van.
So that makes complete sense to me. Andy, I haven't asked you this in the past, and I don't know that you're prepared to answer it, but like the first one, the WAC inflation penalty, is that a little bit of work for you guys or a lot of work for you guys? Because, if we're trying to set priorities for you, something that's very low hanging fruit, we might say go ahead. But if something is very onerous for you to do it, then we might table that to a later date or something, given the staff resources. I don't know if you're prepared to give me a sense of how hard how any of these would be, but that would partially influence my decision of which ones to move forward with.
It's a great question. And I will try to address that. There's one section on implementation of each of these, and I can address that question. Ultimately, it might be something that we flag for your final determination, and you can even, as part of that, probably it doesn't necessarily need to be part of the resolution, but indicate to staff how much time and effort you want us to spend on this. There's some that seem like they should be low-hanging fruit, but if we ultimately find out as we implement that it's a major lift, you can kind of call us off of it at that point too.
And Andy, I think you can explain to the board, like there's some, whether it's the delinking issue that I know George brought up on a couple of his calls that we've talked about, as far as the program that Congressman Romer's involved in down in Kentucky. You can mention some of those things. I think that we don't feel like, Jerry, it's going to take a lot. It might take a little bit of seed money or whatever, but we don't feel like it's going to take a lot of time because we're basically bringing something that another state's already done.
Yep.
That makes sense.
Yeah, but Dr. Anderson, I think I can address your question for each policy. Yeah. But if you did want to indicate prioritization and just through your feedback, I think we're open to that. So just as we dive in, I did want to flag a couple things. We did consider a number of other policies, and there's a number of policies that we're not recommending. So I'll just briefly go over those just for your own information. We've heard from some stakeholders that a copay cap could be a good policy option. This is kind of a plan design option. And we did dive into it, and there are two things already on the book. So you guys probably know about the $30 insulin copay cap that was effective starting in January 1, 2023. And then also when we were doing some background research, we did identify a copay maximum of $150 for drugs prescribed to treat diabetes, HIV, and AIDS. So for both of these policies, we think that it's kind of not a resolved issue, but one that the state has already taken action on. So we're not recommending additional action at this point. There was a lot of discussion in our information gathering around understanding and building protections in for utilization management. We couldn't directly tie that back to any specific drivers. It didn't address any of the findings that the board members had. So we do think that there's additional room to study those, but maybe a different form is kind of the place to move forward with that. There is a lot of talk of broader PBM reform. So for example, even in the public comments that we received today, suggestions such as point of sale discounts, discussions around aggregators and accumulators. There's a lot that's happening in the PBM space, including at the federal level as well. I'm not sure how much legs those have, but there is a lot of discussion happening at the federal level. So one of the ones that we did do a deep dive on was point of sale discounts. And our initial research indicated that that's a substantially heavy lift. It's almost kind of a restructuring of how PBM reimbursement works, to the point that it would require additional development. It's almost kind of like a separate topic. We would probably recommend a separate forum if we did want to embark on something like that. And then regarding the aggregators and accumulators, the legislator did just pass a bill last session related to the copay aggregators and accumulators, basically requiring that plans capture patient assistance programs and coupons towards the patient's out-of-pocket costs for plan design purposes. So the legislator has done some work in this space. It may be something that the board wants to bring up in again, a broader forum where we look at kind of the PBM market as a whole and try to make a policy recommendations. We do have one specific policy recommendation that we're going to move forward, that we are proposing. And again, mainly that's what seems like a straightforward fix. It's not simple and it's not easy, but it is the most straightforward fix just to some of the issues that we see on the PBM space. We also explored a lot of transparency work, especially around WAC transparency, which is tied to the first circumstance. And we ultimately decided that this is information that we can already get through other services. So some states require manufacturers to report WAC increases. We can get it through different files that we already have access to. So we thought the reporting burden wasn't worth it. And then finally, deductible smoothing is a policy that we asked for information on. So this is a policy from CMS that basically, again, especially for high deductible health plans, if patients are paying all the money up front and then very little throughout the year, the plan can actually design it so they're paying a more steady amount throughout the year. We ultimately didn't consider that one because we couldn't identify savings with it to the patient. It helps the patient in terms of like managing cash flow, but it didn't actually save the patient money. So did just want to acknowledge that those are policies that the board staff consider, but we're not making any recommendations on those. All right, so with that, I'm going to dive into each of these policies. I do think we can kind of pause at the end of each policy and answer any questions the board has, if that's okay. So Christine, if you go to the next slide. So one policy that came up, so again, the first circumstance is the WAC is increasing faster than inflation. And one of the most direct policy responses to that could be some sort of WAC inflation penalty. So basically manufacturers pay a penalty on gross Maryland revenue attributable to the increase in WAC above inflation. This is a common idea. So there is there's a inflation penalty. There's always been one in Medicaid. The Inflation Reduction Act created one for Medicare. A number of states have done something in this flavor, kind of around, they call them like excessive price increases and things like that. But it is a very direct policy tool that can disincentivize the increase of the wholesale acquisition cost. I'm happy to kind of talk in more detail of what that could look like, but I don't think we have a specific recommendation on that at this point. But I can talk about that.
So Andy, my question would be, you referenced that some other states have some other type of language I think you used,
Yeah.
and that Medicaid had taken a look at it. What can you give us any kind of numbers or savings or what?
I think the states are early in their process to the point that they probably have not fully implemented. And then Medicaid and Medicare, I think they are attributing some savings to it, but then also the purpose of the policy is to reduce WAC increases. So I think Medicare would probably say, and I think we have some data on this a little bit later, that they have seen a decrease in WAC increases due to their policy. Go ahead.
So in other words, you're saying that what you've seen so far, you think is like, instead of 4%, it's 2%.
Yes, I think the literature is mixed on this, and I'll go over this in a little bit later. But yes, we do think that it is a very direct policy solution to this very specific policy issue. And there are folks that are implementing it and they are seeing varying levels of impact. Yeah.
I mean, it's like I said, for 5 years, and sooner or later, it would be nice to quantify something, to see something, which I always like to see, but we seem to struggle finding it.
Yep. Yeah, I think we could do that for this one. And so Christina, you can go, scroll down. And this is kind of, this kind of addresses your comment, Ben. So first, in the strengths, it does directly provide a disincentive for WAC increases. It's fairly intuitive to implement. I'd say easy to implement. It's actually going to be difficult and complicated, but it is like a straightforward, this happens, so here is the policy used to stop that from happening. And then another strength is that it may be a revenue generator. So if the WACs continue to increase, then it is a source of revenue for the state.
If we were to move forward with this, for example, would DBM be the ones that would?
Likely Treasury. It would probably live with Treasury.
The Treasury?
Or I mean, it would likely be done through tax authority. So.
All right, this needs to be flushed out.
Yeah. Okay.
And Andy,
but be nice if it came into our budget.
Yeah, but I don't.
Since there's you say there's report data out there in terms of showing effects of the policies. And if they are mixed, I think certainly documenting the ranges there of impact, but more interesting to me would be to understand how they were implemented and process differences and to be able to understand the why around the mixed effect. Because to me, this is something that's certainly worthy of further study.
Okay.
So I have a hypothesis on this, and that, in some ways, if the drug is not subject to many of these penalties because it's not used by Medicare or it's not used by Medicaid, the penalties don't impact the industry.
Right.
On the other hand, if it's something that does impact the industry, then they're going to pay more attention to the inflation rebate. And so having the state do this just adds to what Medicare is doing, what Medicaid is doing in terms of inflation rebates. So I think we don't have a lot of strong evidence on this one now, but the more entities that do it, the more impact it will have.
Yes. Yeah, just echoing Dr. Anderson's point. So a lot of the literature is actually on the Medicaid inflation penalty. And one phenomenon that happened was that there was, and so we have internal research on this and can map all of this out for you. But the inflation penalty actually had a cap, so it could never go negative. So then once you hit that cap, there was an incentive to dramatically increase your list prices to make up for the fact that you're giving this inflation penalty to Medicaid. So there's a couple things that are happening there. So that's where you see some of this, like, well, it actually may have increased list price increases because of some of the quirky designs of how the Medicaid inflation penalty worked. I think we are seeing some changes. So one, they did change that rule, and we saw some direct manufacturer behavior changes, i.e. completely changing their list price. A lot of people say that's why insulin prices have gone down so much, is because we eliminated that cap. But then to Dr. Anderson's point, when states implement something like this, it's still a business decision of, do we pay the speeding ticket and then do you still make more the penalty? Do you pay the penalty and then still make more revenue that it's worth increasing the list price? We think that that's a consideration that companies are making when they're raising their list prices. They understand that there's this expense that comes with it as a penalty for increasing faster than inflation, but can they make additional revenue through that price increase that makes it worth it? So that's kind of the why you see mixed evidence there. Then to Dr. Anderson's point, if you do hit a critical mass, then you may actually impact behavior where the math doesn't work anymore and you don't increase your list prices above inflation. But we can summarize that evidence.
Yeah, and one of the key things is the private sector, privately insured, self-insured companies don't have these kinds of things. So for drugs that are used heavily by private insurance, these inflation rebates don't have an impact. But again, the more that have inflation rebates impacts, the more likely the industry will respond.
Okay. So Christine, if you go to the next slide. So this, again, kind of goes without saying, and it's kind of just a statement of observation. Either the policy is going to work and stop WAC increases, which is the problem that we're trying to address, or, and then if that's the case, then the state won't get any additional revenue, or WAC will, or the list price will continue to increase, but then in those cases, the state would get additional revenue, hopefully offsetting some of the harms that come from that list price increase. But that goes back to the mixed results that Dr. Onoko was asking about, is like some show that it has the impact of reducing the list price, others show that it doesn't have the impact of reducing list price, but instead increases revenue for whoever's collecting the penalty. Okay, next slide. And this would be done through legislation and requires additional supporting regulations as applicable. The next slide, Christina. And again, just mapping it back to our drivers, this primarily goes after or addresses drivers 1 and 2 related to WAC increases. So we talked about the current pressures and incentives in the PBM manufacturer negotiation structure, and this basically curbs some of those incentives by putting a penalty on list price increases.
We also have to consider drivers coming out of DC and Pennsylvania Avenue with the president raising tariffs inordinately. It may not be for these particular drugs that we're discussing today, but in the future, something coming in from out of the country, with 100 or 150% tariff increase, that throws a large monkey wrench into all of our considerations.
That's a great point, Dr. Rockhauer. Thank you.
Yeah, the thing, and this, given this is, needs a legislative fix, is, can we make this in Maryland apply to the private sector as well as Medicare and Medicare, Medicaid, and some other programs? I mean, that's something that the legislature needs to consider.
Yes, and Dr. Anderson, thank you for flagging that. That does get to the question of the ask. So what staff would probably do out of this, just based on the feedback that we received, you flagged a couple of open issues that you would like information on to guide further thoughts, including kind of more fleshed out response. And basically what this would potentially look like is resolution from the board stating that you believe that this is an idea worth considering. Staff could take we would first start by collaborating with our state partners that would be responsible for implementing this. Ultimately, there would need to be a pen to potentially draft the legislation. That can either be us or other folks. I think once folks understand the potential implications of the policy, I think we could get a lot of support outside of the PDAB staff to draft the legislation. And then I would not expect this to be an easy bill to pass. I would picture it to be a very contentious bill to get over the finish line. So there is kind of staff resources for that. But, I think the state can decide that the juice may be worth the squeeze depending on how the penalty is structured. So.
Yeah, and if we move forward, I would suggest we don't do any of what Andy just said. Sorry, Andy, but I
Yeah,
would
fair.
just go to a Senate member and a House member, sit down with them, ask them to draft legislation and run with it.
Yeah. Yeah, but the most important thing from the board would be this resolution that we would have, so that if a piece of legislation does make it, you know, out of a legislator's office, you know, they would have the support of the PDAB in this work. So,
Oh, sure. I mean, we would
Yeah.
go support the bill, but I
Right,
mean, we
right.
don't need to be the driver and
Yep.
own all that.
Understood.
And I
Great.
would just add that, you know, across many of the options we have, this is one of the couple that I would say, in terms of having confirmed the drivers and thinking about what could address the drivers, we have a clear link. But to me, that link is conceptual. And I would want more quantitative information, whether it's modeling, scenario analysis, something that we can stand on, in terms of that evidence coming back. Because for those that have already implemented it, just to understand how they're different from Maryland, how they're similar. We've talked about the distribution of comorbid conditions in our population. So there could have demographic differences one can point to easily, but this is policy. And sort of the bones of how the policy was stood up, I feel like I don't have good visibility to. Then
Okay.
even
Yeah, we can provide
that could work
options.
in ours.
Yep. Yeah, there's a few different flavors, so I think we could provide all of those. I don't think there's strong commitment one way to the other from the staff side on exactly how to implement the policy. And then to Chair Mitchell's point, you know, a savings estimate, that is certainly a number that you can calculate. It has a lot of assumptions based on behaviors, you know, projected continued price increases or not, but you can, you know, it's a relatively easy math question. It's more of a what kind of assumptions around behavior change do you incorporate? But that's, you know, that's been done before, so we can figure that out.
Yeah, and the Congressional Budget Office and other places have done analysis of the Medicare inflation rebate, so we could sort of piggyback on that analysis. I don't know if the states have any analysis of their impacts. I think might be too early, but we do have some evidence on the Medicare side.
Great. All right. Thank you. All right, so that's the WAC inflation penalty. Next, staff is also recommending implementation of real-time benefit tools. So this would include the establishment of rules that require plans to adopt real-time benefit tools. So basically, this is software that's integrated into electronic health records that allows patients and prescribers to access real-time formulary and benefit information, including cost sharing, to shop for the lowest cost alternative therapies under their prescription drug benefit. So just as some additional background, this is a requirement for Medicare plans, as we understand. I think it was included in the Inflation Reduction Act. But right now, as we understand it, different plans are already doing this for their Medicare book of business. So staff thinking on this is, if this is a tool that is already in nature and readily accessible, and you know, it could be as easy as just flipping a switch to expand into the commercial sector, then it's potentially worth moving forward with. I think we have done some kind of cursory exploration of that, and it may be a heavier lift than what we were suggesting. And I think we look forward to feedback from our plan partners on this. So general thinking is, if it's a tool that would be readily accessible, it can help patients. But I'll go over some of the pros and cons and the benefits in just a moment, to kind of leave it up to the board on thoughts on this. So if you go to the next slide, Christina. So the strength is it builds on existing software and integrations developed for Medicare. And it also gives patients the ability to make a more informed choice about cost prior to picking up the drug at the pharmacy. So one of the big frustrations for both prescribers and patients is the prescriber makes a therapeutic decision with no information on the cost, when there may be a drug that they also, you know, would consider as an appropriate therapy that would be cheaper, and they just have no insight into that. So that's kind of the problem that this tool is trying to provide. One note is, or some of the weaknesses, is that it doesn't actually lower the out-of-pocket cost for a specific drug. It only helps the patient identify the drug that is the best drug based on their plan, the most cost-effective drug based on their plan design. And then also, as we understand it, it may be operationally complex. It does require integration between health plans and pharmacy switch providers and EHR vendors. I think it was a heavy lift to get it to this point. So our thinking again is if the heavy lifting is done, let's take advantage of it. But it may not be worth it if it's additional, like an equally heavy lift to bring it to the commercial market. Next slide. So one thing to note is that the literature is limited on the impact. So we did try to include some of these citations. It's been pretty well studied on the impact of these pharmacy benefit tools. And again, at a very high level, it can help a certain number of patients. Again, it's usually very small percentages of patients, and the savings are often relatively limited, but a lot of this seems to be based on the limitations of uptake. So it may be one of those things where, again, once you get to a critical amount to the market that's using these tools, they may become more effective, but this kind of limited rollout of these real-time benefit tools has shown limited impacts in the literature. So I think we did just want to put that caveat in there. Again, the staff is thinking if it's a tool that is already there, why not use it? But again, balancing the pros and cons, that can change dramatically based on the actual requirement for implementation. Also, I think some of these reports share differing experiences for prescribers. They can often be kind of a burden for prescribers to use, and if the prescriber doesn't feel that it's worth the time, then they often may not use it. So those may be some of the challenges. The last thing to note is that the systems that these programs seem to be best integrated and used in are large health systems, the ones that have a lot of IT infrastructure. So there may also be a challenge for kind of your smaller shops that have to invest in EHRs and things like that. So again, our hope would be that folks have already had to make these investments for Medicare, and you just flip it over to the commercial population. But did want to just flag that there are some potential risks there. Next slide. This could occur through, again, legislation and or supporting regulations. I think if you are expanding beyond the Medicare population, it makes sense to do it legislatively. And I think that would kind of flesh out some of these questions and details that are still available. So what this would look like, again, is probably supporting in principle the use of real-time benefit tools as available, but carefully balancing the costs and challenges associated with that, with the nominal benefits that we see in the literature. Any questions or comments there? Yeah.
Going to Jerry's question earlier, though, and I know this is only 2 of 3 or 4, but if you ranked from a time element for staff, 1 versus 2, which one's greater time?
I think we would be more hands-off for 2. So the way that we would picture this happening is the staff does not feel particularly strongly on this policy. It would be almost a recommendation from the board into the environment, and then kind of see general uptake on that. Okay. So I think, yeah.
That's fine.
Yeah.
Thanks.
So I'm concerned about this one for 3 reasons. The first one is ERISA rules. Trying to interfere with the self-insured companies is always a huge challenge. So I think we'd run into ERISA concerns. The second one you mentioned is the complexity of this, especially for small plans, small insurers, small hospitals. I think this would be a significant burden. I realize that they have to do it for Medicare, but there is a complexity. And the third one for me is enforcement. Who's going to say that Mary Smith, who's got either no insurance or has some kind of insurance that's out of state, is in fact has access to this tool? I mean, I just don't see who's going to do the enforcement to make sure that everybody has access to it. So I think it's a great idea, but it's going to be really hard to implement.
Yeah, I agree. I see this as
talking about state employees and retirees.
No, I'm talking about more broadly. We could do it just for state employees and for even for the counties maybe, but I think again, what might work in Baltimore might not work in Garrett County as easily.
No, I
Well,
agree, because
then I think
a lot of
Rob
this
has to do it.
a lot of this comes on the physician prescribing side through the EHR. Now, as you said, if I'm working for University of Maryland or Luminous Health, I've got a lot of IT behind me. But if I'm in a two-man shop, just contracting for an EHR, a freebie EHR, which there are those out there, they're not going to have this available. So this is a very complex tool that I don't think is going to work very well. The whole idea of integrating pharmacy benefits to an EHR has been bandied about since the early part of this century, and hasn't really happened, despite a lot of the Office of Management and Budget and Office of the I forget the initials, the Office of the Computer something or other, trying to get it accomplished. This is a very tough thing. Even in the Medicare space, there are lots of different drug plans, and so that behooves the physician's office to know which plan the patient has to get it into their EHR, so their EHR knows what to recommend. This is tough. This is very, very tough.
And I would also, Dr. Rackauer, staff appreciates those comments. I think you're flagging the issue. The reason this I think was a staff recommendation is this is one of the biggest frustrations for us. We'll talk about a patient navigator program shortly, but one of the biggest challenges for patients is they just literally have no idea how their plans work. So it seems like
I agree. And the doctors don't know it either.
Yeah. It seems like an intuitive, to your point, it's something that everyone has been trying to fix. So if our efforts can inch that rock up the hill a little bit more, that's kind of what our thinking was. But going back to Chair Mitchell's point of what kind of resources do we want to put into it? I do think it is a very Sisyphusian effort at this point. So
my thought here too would be similar to others. I have concerns, maybe for slightly different reasons. If we go back to the drivers that we're really wanting to address, I don't see how this directly links to those drivers. Plan design is one thing, but then the tools helping you navigate it, not necessarily change the structure of it, which is the driver actually. And then I don't know how much has been done on cost validation of the tools. I know anecdotally people have not had good experiences from that standpoint in terms of what it tells you on the screen, if you will, and then when you get to the pharmacy, what you experience. And I think the literature on that is limited, but to me, that's fundamental to understanding how useful will this be to patients. If it doesn't have good cost validity properties, then how is it actually helping them?
Okay. Yeah, so I'm hearing if the board, and the board may not want staff to spend additional resources on it, but there are a number of questions you've asked where if we were to move forward, we want to clarify things like scope. Would recommend it just applying to employee or state and local government health plans versus more broadly, and then also cost benefit analysis of these kinds of tools. So
sorry to clarify, not cost validation, just is it correctly indicated?
Even more simple question. Yeah. Yeah, fair enough.
Yeah, and I understand Jerry's concern at the beginning as far as the ERISA plan, but we've legislated in Maryland around that issue ever since small group reform back in the 90s. So, I think there is a way if the group wants to move forward with it.
The only thing I would add, Andy, is cash paying people. And sometimes paying cash is actually less expensive than using your insurance. And yet, I don't know that this tool would have what you would do if you actually could pay cash for this. So that would be another wrinkle that would have to be added and I don't think Medicare necessarily does that.
Okay, great. Thank you for the conversation. This is very helpful. All right, if you're okay, we can move on to the next policy. Yep. Okay. Yep. Next up, this is one that came out of the information gathering. The staff, we've talked to the board about this for years, basically kind of identifying again just the issue that Dr. Rackauer flagged, that a lot of patients can theoretically, even within our current system, be paying less money if they knew how to navigate this complex supply chain. So staff has internally been working on our own kind of navigator program. And right now it's very ad hoc and very boutique. Patients do reach out to us that are referred to us, and we do kind of walk them through an algorithm of, okay, here's the drug that you're trying to get, here are the different steps you can take to try to make it more affordable. Through our information gathering, we did stumble onto a more scalable kind of subset of that work. So one thing we can do is establish a patient assistance program. There's a couple of versions of this. The one we specifically referenced and that came up in one of the informational hearings actually was the Kentucky Prescription Drug Assistance Program. And basically what this does is it focuses, this is probably, I don't know, like third or fourth tier on our algorithm, but it focuses on getting patients into patient assistance programs, which are often very administratively burdensome to enter, and then also generally hard to navigate and tough to tell if you can even qualify. So there's technologies out there and different vendors that you can put patient information into, and it automatically bounces off of the different patient assistance programs and lets the patient know which ones they qualify for, and then the navigator program basically helps them enroll in this. So it's almost taking advantage of existing private sector resources to make prescription drugs more affordable for patients and just letting them know about the resources that are already available. Next slide. Yeah, we'll talk about this in a little bit. So the strengths that it uses existing patient assistance programs, and I think the ramp up is very quick. I know the board is always looking for something that can help patients tomorrow. A lot of these kind of longer term policies that require legislation and things like that have a long runway. This is something that theoretically could help patients starting the day that we start doing patient outreach. It also builds on existing state resources. So we do have a number of programs that try to get at some of these issues. We do have something called the Senior Prescription Drug Assistance Program. And then the Maryland 211 program does have a like prescription drug affordability element to it. All of those can kind of be built out more. The programs have a strong return on investment. So we'll go over that in just a minute. One of the weaknesses, and I think this is worth acknowledging, is that I think we've had this conversation when we were doing things like our supply chain report, is that their literature suggests that these tools may push patients onto more expensive drugs. The reason these patient assistance programs work or exist is because the patients have a choice between a non-preferred drug or a drug that a very expensive new drug, and there's competition that is cheaper. So these resources are available to help the patient afford the more expensive drug, which may have kind of broader consequences to the health system as a whole. So I think that is something that the board can kind of explore in a separate setting. I think the staff thinking is, if these resources are available and they can help patients, we should take advantage of those resources until the board decides, broader policy decisions around the larger impacts of these kinds of programs to the health system. Next slide. I'll just keep on talking about the program briefly. If you go back up, Christina, just really quickly. I'm not sure if you covered one. Yeah. Okay. No, go back down one. I'm sorry. So the impact. So there were a couple of reports that were published. You can go back up. I'm sorry, Christina, to the actual cost. So there's one program out of Kentucky that we reference here, and then also there's a program out of Washington that has a slightly different flavor. I think it's instead of being a state agency, it's had seed funding from the state, but then is now a unaffiliated nonprofit. But the Kentucky model reports that for a cost of about $600,000 a year, it supports over 6,000 patients with 23,000 prescriptions and provides a total value of patients in excess of $53 million on those prescription drugs. So this just shows, I mean, the math can be a little interesting. I think there's some important assumptions in there, but it does show dramatic return on investment. So again, the strengths are that it can help patients starting tomorrow, and for a relatively limited or small investment of state resources, it can have a dramatic impact on Maryland patients. Next slide. There's a couple, you can do it through legislation or regulations. We've been, again, over the past 3 years, just kind of kicking the tires on doing something at a smaller scale without legislation. But the benefits of the legislation, as Kentucky has, is that it does include kind of a stronger framework and funding that's necessary to develop the program. So it would kind of move things along and set up a more standardized structure that's more scalable. Next slide. Again, this directly addresses some of the drivers in 2.1, 2.2, and 2.3, because those three patient groups that we had talked about are all insured patients. And so theoretically, they could qualify for these kinds of programs, and these programs would be able to help with their out-of-pocket costs. I do also just want to reflect that this is a very common point that comes in through our comment letters. It's something that is, up to this point, our board has not been able to quantify or capture. It's very difficult data to actually assign to. So what we see is what the insurer is charging, what the patient's payment amount obligation is based on the insurer's calculations. We don't see these patient assistance programs, and almost all manufacturers that have responded to us say that these patient assistance programs are an important tool to make prescription drugs more affordable, and they tout all kinds of statistics that say that this is why drugs are affordable, because of these patient assistance programs. So just flagging that is a recurring comment and theme that you guys have received from our manufacturer partners. Yeah, so that's the patient navigator program. Any questions or comments on that?
My
Go ahead,
question
Karen.
would,
You're first.
so maybe it's terminology, just because to clarify, because my first question was, why do we begin with the patient assistance programs to stand up the patient navigator program?
Yeah.
Is that because that's been the way it's set up? So for example, with Kentucky and the 6,000, my question is, how does that 6,000 compare to the underlying demand in terms of those who need it versus those who are in these programs? Because the programs can be very specific.
Yep.
Right? Some of them are broad, some of them are for a specific drug. So if it's about reach to those who need, that would be my main. I think I'm a big proponent of something that allows individuals to have better information, and this patient navigator program is something that I'd be interested to learn more about.
Yeah.
But if we're running it through existing programs, then my question is, what is the ultimate reach there?
Yeah, it's a good question. So one thing to flag is that most of the patient assistance programs are means tested. So it is a subset of Maryland patients that would even qualify for these programs, and we're not adjusting any of the rules at this point of how those programs work. We just kind of take them as they are, and what this does is help the patients understand if they qualify for them. So that's a great point. Another thing to flag is, because it's a manufacturer-sponsored patient assistance program, there's no guarantee that it's going to remain available to the patient. We're kind of at the whims of the folks that are sponsoring that program. At any point, they can cut that program off, and that's one of the weaknesses of these patient assistance programs. But the reason we're starting here is because it is such a currently structured, scalable program. One of the things that we learned when working with the folks from Kentucky is that the way we were thinking about our navigator program, which is, again, patient can't afford their prescription drug, calls hotline, talks to a patient navigator walks them through a series of questions to identify the best solution for them. And then, like, the third option on that list is the patient assistance programs. It's just extremely resource intensive in a way that we don't think we understand. So we have anecdotal evidence just based on our own experience in space, but to actually stand that up is not the amount, like the investment would be substantially more than what we've indicated here. So because this is a very plug and play solution that addresses a very specific part of the problem, that's kind of why we were looking at it. It's an existing framework, very scalable, relatively straightforward to implement. Someone's already done it, so we're basically copying and pasting, whereas our navigator program will continue to be probably a long-term project that we continue to develop. So I would say that this, the reason I do call it a navigator program is, we're going to keep our general framework of, this is, again, one tool that's available to patients, but we're also going to do as much as we can to explore these other tools. But this is going to be the most robust, just because this platform already exists. We know how to train people on it. We know how to build our outreach. You asked about the number of patients that would be eligible. We have some back of the envelope math that I don't think we're ready to share at this point, but we have heard from the folks that administer the program in Kentucky that they are not meeting the demand now. That 6,000 patients is based on the challenges of scaling up and getting the volunteers that can go into the field and reaching out to the patients that can benefit from it. So they think that the 6,000 is low, and they're continuing to expand it. They're actually, I mean, it's very
Yeah, I
impressive what
believe
they're
it.
doing.
Yeah.
So we think that there's, again, thousands of patients in Maryland that would benefit. Yeah.
I mean, I think that's great too, to think about how to build on something that already exists. It reduces that resource investment up front. And we know for sure with the PDAB, it's some small but mighty staff. So we want to be kind of thinking about what's feasible. With regards to reach, I think that we could also consider other organizations that have a much broader reach as far as getting out there, identifying people who are financially burdened, who aren't necessarily working through a patient assistance program, but they are actually out in the community, and have that kind of reach in Maryland. So I feel as though it's a design question for me, is do we start with that infrastructure or start with other infrastructure that exists that might actually be broader?
Yeah.
And the number of organizations I can think of already who I know are already in that space thinking about financial burden and and who already are in communities reaching individuals.
And I don't want these comments to be, for my board members to be taken out of context, but we don't have Hopkins budget. You've heard me say that before. We don't have University of Maryland. We don't have budgets like that. We don't have a lot of people on staff to talk about the theories and things. And one of the things that is very frustrating to me coming from a small business private sector is that we have accomplished basically nothing. And when I start to push Andy to look at where's the low hanging fruit that we talked about 5 years ago, are there things that are ready to go? Is it perfect? Probably no, but is anything perfect? And so I say to all of us on this call that, if you have something to bring forward, bring it forward, because we've certainly been waiting to put things in implementation. And, whether it's upper payment limits or not, none of it's been proven from that perspective. So for me, it is extremely frustrating because I feel like I'm the steward of the time and money, and the return on investment is terrible at this point in time. And I'll just say that publicly, and I think I've been pretty consistent. I don't think it's all our fault, but we can't keep talking and waiting for the perfect solution or think that we're going to hit a home run on every single issue. If it helps people in Maryland and retirees and current employees, then that's what we should be doing. Small, large, medium, or large. At this point in time, I don't care. I just want to help somebody.
I'm with you, Van. I mean, I forwarded some contacts for certain organizations to forward maybe, I would say a year or 6 months ago, as I see people hold programs designed to reach people who are financially impacted. And I would love to see some of those organizations which have boots on the ground in Maryland involved in some of this effort. So I think as we move any of this forward, I'm a big proponent of starting and then continue to evaluate.
So I would agree with Van and Barry that we should start and pay attention to it. I just, being the academic, have 4 concerns. And, Van will be upset with me, but I'll still say them. The first one is coupons are dependent on the companies giving the person access to the coupon. And so the navigator might say, you've got access to this coupon, and the company says, no, you don't. So that's my first concern. The second one, and Andy talked about this, but what most of the literature suggests is that the more expensive drug is often the one that gets the coupon. And so, it could be that it lowers the price to the individual, but increases the price to the state. And so as we look at what this navigator in Kentucky or Washington State does, I would take a look at that issue. The third thing is most of these plans don't cover the uninsured. You have to be insured to be access to one of these things. So this navigator, if somebody's uninsured, most likely will not benefit. It could be in some cases, and there are some places where they do give out free drugs, but that's different than most of these navigator kinds of things. And the fourth one, and this is maybe not an issue, but is the whole issue of liability. If we say you should go here to get this drug because it'll be less expensive than that drug, is the state making a recommendation about which drug to take? And if it is, that could be a challenge to me.
Well, the insurance companies make recommendations like that all the time when they set their tier levels.
Absolutely.
So are they at liability? I don't think that that's been a successful lawsuit because somebody took a cheap drug and they had a problem and therefore they sued their insurance company. I don't think that's ever been happening.
No, but when it's the state government, it might be a different story.
Well, they're bigger. They're bigger pockets than we are.
Whatever. I don't know if this is true. I'm just always concerned about the liability.
And I'm just saying this, that in 1996, I sat in Economic Matters, my second year after small group reform had been passed. And Mike Bush and Tommy Bromwell's whole mantra that year was to lower the underinsured and uninsured Marylanders, right? And we had a number back then. I don't remember what it was, but we had a number. And we all thought we were doing the right thing. We all thought we did a great thing. But over the years, guess what? That number's continued to grow and grow and grow. Well, one of the reasons it's grown is because Maryland's gone from 4.5 million to 6.5 million in population, right? So, I mean, my point to all of this is like somewhere along the line, we just need to start and we need to do something. And if it has catastrophic effects, then we need to correct it. But if it doesn't and it helps somebody, then let's move forward to the second thing and let's move forward to the third thing. And let's try to get some momentum to go forward. We know we're going to get sued. We know we're going to make mistakes. We don't have all the answers. And this is an extremely complicated issue, like we all know. But if we don't start climbing up the ladder with little things, I just think we're going to be here. Somebody's going to be here. It won't be me. Somebody's going to be here 5 years from now doing the same thing.
I'll join you on the ladder.
Thank you. We appreciate the discussion. Okay, anything else? Okay, the last non-UPL policy that we have is around PBM compensation. So a lot of what we discovered in our informational gathering was around some of the incentives that can be created around PBMs trying to maximize their rebates, and then the power that manufacturers have to increase those list prices. So we did hear, and I think we even heard it in some of the public comments today, about potentially delinking PBM compensation from rebates or WAC increases. PBMs are often paid based on the percentage of rebates that they negotiate, which provides an incentive for preferring drugs with a higher list price and larger rebate amount. So there's two flavors of delinking that we included. One is basically just a flat fee rather than rebates. So there are some PBMs that have a model of basically doing a flat fee per script processed. And then there's another model where you can set the WAC at a point in time, and then rebates are derived from that amount. And what that does is it eliminates the incentive to increase the list price to get a larger rebate. The way you negotiate larger rebates in this case would actually be to continue to decrease the net cost, which is ultimately what folks think is what's supposed to happen through these negotiations. But because list prices can be so easily increased, we haven't seen that happen. Next slide. I do again want to acknowledge that this is part of an extremely complex system in terms of PBM structure and reimbursement. And this is just one small piece of that. This is a policy that is has, again, a simple concept behind it, though, again, very complicated and difficult to implement. That's why we're doing this one out of many things that can be done around PBMs. So the strengths is, again, and it also is most directly mapped to one of our drivers. So the strength is it removes pressure from manufacturers to increase list prices for the purposes of being able to compete on rebate. And then it also increases or reduces the incentive for PBMs to prefer high list price products. A couple of the weaknesses, I think if we channeled the talking points from some of our industry colleagues. If you move to strictly a flat fee, it removes some of the incentives for PBMs to negotiate as aggressively as possible. So theoretically, it could increase the net cost. And then also, I think we've already seen this with some of the national policies. But if if there's penalties to WAC increases or derivatives of list price, that may encourage higher launch prices. So for new drugs coming to market, they may have a larger list price just to bake in this policy. So that's just another thing to consider. Next slide. Again, there's limited, so there's a lot of plans that have this structure. In fact, many of the large PBMs have a product that is based on either flat fee reimbursement or delinking rebates. And this study shows the largest percentage, but isn't directly, it studies the system as a whole. It doesn't actually study like plan design. And it basically suggests that if you remove the incentive to favor high cost, high rebate drugs, it could lower overall spending to the system by about 15%. Again, that's not saying that a customer's cost from their PBM would be 15% less, but as a net positive to the system, they propose that benefit. One thing I would just say that we've kind of seen anecdotally more than anything else is, again, PBMs would often say that this is they have a product that does this, and very few clients or customers or plans are using that product. And that by definition shows that it is not a good product to use. So I would just flag that these kind of do exist in the wild, but the uptake has been very limited. So that's just something to consider. But that, that's, yeah, again, just a factor for the board to consider. Next slide. This would likely require legislation and supporting regulations as applicable. And then next slide. And it is directly mapped to drivers 1.1 and 1.2. Again, it just decreases some of these incentives that we currently see in the system to increase list price or WAC. So, so you can go back up one more. So that's the last policy we're recommending. Again, it's part of a larger puzzle related to PBMs. So it's a matter of if the board wants to tackle this one issue now, or if the board wants to do a more in-depth dive and discussion on PBMs as a whole. But this is something that came up in our policy review, and it is a straightforward policy recommendation that addresses one of the drivers.
So I very much like the idea. I just wonder, do we run into a dormant commerce clause problem here?
I should have addressed this because you flagged a number of legal issues. All of these policies will receive legal review, and all legal issues will be identified, probably not for public consumption though. So we will work through all legal issues that are open. So I think you're flagging good legal issues, but it's not something we need to discuss in these meetings. Yeah.
Yeah, and I mean, my comment, as it was last week in the staff meeting, Andy, remains the same. I think there's been PBM legislation in the Maryland General Assembly now for going on 12, 15 years, every single year, piecemeal. I really think this has gotten to be like deregulation or, small group reform or whatever. This is one of those scenarios probably now where there's a good 8 to 10 pieces of legislation that could get put together through a work group by the legislature and have a joint hearing, joint referral. I know the industry won't want to hear that, but I really don't care. And I think as many of the issues that can be flushed out, you're better off trying to get them in a big package than you are one-offs, because one-offs you're going to just get picked off year in and year out, and you're never going to get anywhere with it, whether it's us or a senator or a House member.
Great, thank you.
Yeah, I
Any
agree.
other comments,
This is a very big package to be able to do with, and I'm not 100% sure we'll be able to do it on a state level. But it's
And
certainly
with,
an interesting idea.
Okay. And I'm always thinking about where can we hit at the pocket for the patient soonest? And this wouldn't be high on my list with that as a kind of initial priority.
Great.
So it sounds to me on the 4, just my ears, you guys correct me if I'm wrong, that there seems to be a lot of appetite for 1, the whack inflation, and there seems to be maybe something for 4, the D-link on the PBM.
Oh, I'm not sure that delinking on the PBM is very doable. Unless, as you say,
Well,
we get
I don't think we're here to say whether something's doable or not.
Okay.
I mean, I think what we want to do is say to Andy, either he moves forward or Van moves forward with legislators or combination, or that the board feels like this is something that should be pushed. Again, the board doesn't have to do the work. Some of this legislative stuff that's what legislators get elected to do, and that's what they, like to do. We created a Health and Government Operations Committee for a reason, because we used to do joint referrals between environmental matters and economic matters, and it was just not a good thing. And we said one committee needs to do all healthcare. So that's what they do. So if we want them to pick up the mantle and try to run with it, I think that's how this bill got passed. That's how this board got passed. It was a big bill. It was a 4 or 5 year struggle.
Mm-hmm.
So
I would definitely put in for a recommendation for 1.
And I would agree with Van on 4 in that, the board and Andy have a lot of expertise in this issue. And so we could provide expertise to the legislature if they asked. So I think we should, be prepared to answer questions by the legislature on it. I agree with Van that we probably don't want to take the lead on this, and it should be a much larger piece of legislation, but we could help the legislature in, whatever they're discussing in terms of PBM reform.
I can get behind that.
Yeah, I think that's fine. I mean, that was more considering where Andy and his staff put their time, but this is more serving as resources. Sounds like that's how you described it, Jerry. Then this is for number 4, correct? That was
Correct.
different to my understanding, and I would be fine with that.
And then anything on the patient assistance program?
Well, I like that
I'm
idea, but that's not necessarily, going to work across the state for, because each of the I don't know, do state employees have different plans, group different plans for drugs, or the county employees have different plans for their drug plans, or do they just get 1 or 2 choices?
Depends on the county. Yeah, state only has 1 prescription drug plan, but some counties.
Yeah, so for the state employees that only have 1 prescription drug plan, having a navigator is not necessarily going to find anything cheaper unless they can recommend a different drug that might be cheaper for them. And then you got to go back to the doctor, to change the prescription. That's complex.
Okay, sounds good.
So Andy, because we're considering the patient navigator program for Jardiance or Farxiga, for those specific 2, not.
I think it would be generalized. No, I think it would be generalized. The patient.
Oh, it would be generalized.
Yeah,
I see. Okay,
yeah, it's
thanks for
agnostic
clarifying.
to drug.
Because in that case, I would be more interested to move forward to learn more with the patient navigator. I thought it was specific to.
Yeah, sorry for not clarifying that.
Thank you for
So-
clarifying, because then I'm with Stephen, like, what choice, not many choices available and how much benefit for a navigator program. But as a general tool, it is something I think we can explore.
Andy,
Okay.
I know we have because we set it up this way, because of lack of staff. I know we have a partnership with MHBE. Is this, and I just thought of this, is this something that possibly we could talk to Michelle and their board about? Could they utilize it as well?
I would have to double check the rules, but my understanding is that the ACA plans or exchange plans don't prohibit the use of patient assistance programs.
Right.
Long way of saying I think it could help their clients. Yeah.
So that might be a scenario where we could help a couple of us and share the cost.
Sure. Great. Yep. Okay. Sounds good. So that's the non-upper payment limit tools. I think the second part of are you guys ready to move to the next part of the presentation? Great. So the next part is policy action in the form of upper payment limits. So we do divide it because these would follow a separate process from all the policies that we just discussed. And in this case, we have staff observations. This is the item that the board has the most direct authority, the policy that the board has the most direct authority to implement. So we did want to make sure that we fleshed out and discussed this policy. But specific to these drugs, there are certainly strengths and weaknesses. So the staff is framing this more as observations to leave the decision ultimately up to the board. We did flesh out the option for both Farxiga and Jardiance. So next slide. So the upper payment limit, the policy itself is that the board may use its current authority to establish upper payment limits for certain state and local government entities. These UPLs, as articulated in our action plan, would limit the final net amount that the state and local government would pay for drugs. So again, this is what we spend a lot of time with on our upper payment limit action plan. If we implement for state and local government, we would expect that the payment amounts that, as seen in the Maryland drug supply chain, would remain the same. This would generally be implemented. You heard a couple of commenters refer to supplemental rebates, but basically what our UPL is setting the net price to the state employee or the state and local government. And then the way that you can get to that net price can be through a number of different mechanisms. One of them can just be getting additional rebates back to get you to the net price. So that goes towards some of the questions later. That's why I spent some time just kind of repeating that element. Next slide, Christina. Yep. So the strength of this policy is that it will ensure that the affected entities' net costs are protected from WAC increases. So tying this back to one of the circumstances that you identified, which is the WAC increases, that does create upward pressure for drug prices, including potentially net costs. So basically what this policy does is it helps to protect the covered entities from particular WAC increases. For the weaknesses, one of the things is it's indirectly related to the manufacturer decisions to increase WAC prices. So as we map back to different circumstances and drivers, this it doesn't directly impact the manufacturer's decisions around WAC price increases. Also, this is going to come up when we go through the different factors that you need to consider. But the impact of the savings to the state and local governments is going to be based on the net price that the entity is currently paying and the UPL amount that you set. We'll get into this in just a little bit, but any savings that can be attributed to this need to be savings off of what entities are currently paying for those drugs. And then finally, this came up in the dossiers and then also through additional staff research and public comments, that Farxiga may have generic competition as early as April 4th, 2026. Just a couple things to note, just because that is, kind of the unofficially published date that some of these patents expire and some of these exclusivities expire, that doesn't mean that a generic is coming to market on that date. And there's a number of things that can happen to keep the generic off the market, but it is worth noting that generic may become competition may be coming in the foreseeable future. Next slide. These upper payment limits would be implemented through regulations. So this is required in our statute that each time we set an upper payment limit, we would be publishing a proposed rule that would then be implemented as a final rule. This would specify the UPL amount for specific eligible governmental entities, and then also would include the prospective effective date of implementation for each of the entities. Next slide. In terms of the drivers that it addresses, we believe that it addresses drivers 1.1 and 1.2. Again, upper payment limits would limit the impact and effect of WACC increases on certain state and local governments by establishing a ceiling net price that is not contingent on WACC increases. So again, it protects these entities from WACC increases. Then there's some additional considerations specific to the upper payment limits. So if you move forward with an upper payment limits policy, there's additional considerations. You can go to the next slide, Christina. First, you need to consider the cost of administering the drug and delivering the drug to consumers, as well as other relevant administrative costs. I can just say that if we move forward with the next step, which is developing the framework, and then the subsequent step of developing the methodology, all of that work would include administration costs and other administrative costs. Next, the board needs to determine whether an upper payment limit is an appropriate tool to address the drivers of the affordability challenge identified for the prescription drug product. And that's kind of what the board is doing now, is deciding if UPLs can be an appropriate tool to address the different drivers and circumstances you've identified. It also needs to be set in a way to minimize adverse outcomes and minimize the risk of unintended consequences. This gets back to how we propose to implement the policy, which is through kind of this, again, rebate mechanism rather than changing payment amounts throughout the supply chain for this very specific market. Also, it needs to prioritize drugs that have a high proportion of out-of-pocket costs compared to the system net cost of the drug. This is actually the second circumstance that the board identified. So this, we will check to this box by prioritizing these drugs because of that phenomenon that you've identified. Christine, if you go to the next slide. The board shall not set an upper payment limit if the spending on the prescription drug product by an eligible governmental entity is less than the administrative cost to implement such an upper payment limit. And the third circumstance that you have of this high gross spend has checked that box. Also, the prescription drug product, you can't set an upper payment limit if there is a generic and there are 9 or more marketed therapeutic equivalents. And then these two are important points to address. One, the board shall not set an upper payment limit that impacts the statutory or regulatory amount. So that's something that would come as part of the methodology and framework, something we would take into consideration as we come up with the upper payment limit amount. So not something you necessarily need to address here. The last one is something that is probably worth discussing on this call. The board set a regulation that we can't set an upper payment limit amount that is lower than the Medicare maximum fair price. And both of these drugs do have Medicare maximum fair prices. That means that they have been subject to Medicare negotiations, and they have this metric that has been negotiated with Medicare. One thing that I think it's an observation worth noting that I don't think we fully accounted for when we created this rule is that Medicare seems to be allowed to negotiate additional costs from that maximum fair price. That is not necessarily the net price that Medicare is paying. They can negotiate additional costs off of that. So this maximum fair price may not be the lowest price that is seen in the market. So I did just want to flag that, but we have set that as a floor for ourselves. If we're setting a UPL, we can't go below the maximum fair price. Any comments, Chair Mitchell? I saw you come off of mute for that.
So the maximum price is not really the maximum price.
I'll leave that to your words. Yeah. But I think that's I think the literature has indicated that. Yeah. And we can talk through the implications of that. That goes to the weaknesses that I had mentioned above, that any savings that the state can realize through setting an upper payment limit is limited for these two drugs at whatever the maximum fair price is. So savings estimates may not be what the board would originally expect based on this kind of floor that we've set on the UPL.
I think that's where I struggle with regards to our remit, which includes, setting, if we're going to set a UPL, doing so in a way that minimizes adverse outcomes, minimizes risk of unintended consequences, because there hasn't yet been that modeling of projected savings if we were to impose this floor of Medicare's maximum fair price.
Yes.
So
I mean, I can respond to that. Yeah.
I think, Barry, you're right. And that's something that, if we decide to move forward to this, that's something we can do in the next step. So that's sort of, I agree with you that we need to take a look at that issue, but I think it's something if we decide to move forward, that's the next step to take a look at.
Yeah, and so that's a conversation I do want to have, is what does that look like? I mean, we haven't yet, as a board, I would say, retained a group to do some of that quantitative modeling for us, or scenario analysis, or what have you. But for some of these decisions in front of us, we would need that, I think, as critical inputs to be able to decide whether to move forward with any implementation. I certainly think that we can talk about moving forward with gathering more information. I think that was kind of the original discussion we'd had at the top of this meeting. But kind of with our remit, we would need more than potential scenarios. We would need some quantitative data, I believe, specific to Maryland.
Yes, I can just provide an initial reaction to that too. So I think that's staff's top priority as well, is understanding the potential savings from different policy options. And I do, to Dr. Anderson's point, I think that staff can further flesh that out. Up to this point, we haven't recommended, the next step is basically to recommend a framework, i.e., do we recommend value-based pricing? Do we recommend reference pricing, which is mapping to an existing price? So that hasn't been done yet. And I think that's the next, if you indicate to staff that it's worth continuing to spend time and resources on this, that is the next step for us, is say, okay, here's what staff would propose. We recommend, one of these frameworks. Here's, and then that would also allow us to flesh out some of those additional savings that you have indicated. The one thing I will say too, I mean, the board has seen what was provided through the request for information process. But one of the major barriers that we've run into, and I think we knew it was going to be a barrier, but it's continued, we've continued to come at it from different angles, and it continues to be an issue, is just access to data that you would expect to, the data that we need to answer your exact question is very sparse. I think, the further along we get in the process, the more leverage we have to get some of that data. But up to this point, it's very difficult for us to answer some of those simple questions that you have, just because some of that data is not available to us. So.
That's a good point. Thanks, Andy.
Yeah, and if you want, I can just go through this last point. And actually, if you want, I can walk through both drugs pretty quickly, because it is the same discussion points for both, and I think you can talk about the policy as a whole. So we did make sure that we consider the use of the drug by eligible governmental entities. So this is the information in the dossier on state and local government usage, and then also Medicaid in the next step. The board, obviously, you guys use this information to make your preliminary determination. So this is not new information to you. We are continuing to work with specific governmental entities to see if there's more stratified data that we can make available. But again, a lot of that is based on certain confidential proprietary information, and it continues to be incoming. So that's
so Van, when you asked me, I mentioned, the numbers, these are the numbers that I was referring to. So it's, in this case, 1,700 or so people, and, $7 million. So that was the numbers that I was referring to.
Right, and I just wanted to, I knew we all had used these numbers and had looked at them, but I just wanted to make sure that's what you were
That's
talking about.
exactly what I was looking at.
Thanks.
Great. So that's for Farxiga. We can move on to Jardiance, and it's going to be a lot of comparable discussion points. This is the Medicaid spend for Farxiga. In the next slide. So we also provided staff observations on upper payment limits for Jardiance. So again, I already explained how the authority would work. We would set a UPL, which would be the net price for state and local governments that are participating in the policy. Next slide. Again, the value of this service is that it protects certain entities from WAC price increases. So that's how it maps to one of the circumstances. Same general weaknesses that you need to be concerned about. And it's also worth noting that so any savings will be based on the difference between the UPL amount and the net price that the covered entity is currently paying. And then also, Jardiance also does have a generic that can theoretically come to market in the foreseeable future. In this case, it would be October 15th, 2027 is kind of what we've seen in the literature that's available. Again, that's kind of the earliest that they can come to market. That doesn't mean that a generic is coming to market at that point. So that is an important consideration. Next slide. And again, probably no new information here. Again, it would be implemented through regulations. The regulations would indicate a specified amount, and then the eligible governmental entities that would be subject to the upper payment limit. Next slide. Sorry, Christina, one more. Again, the drivers that it addressed are related to the WAC increases and the leverage that WAC increases give to manufacturers when negotiating plan design. Next slide. Again, just going through regulatory criteria, everything is the same. So again, for administrative costs, that would be accounted for in the framework and methodology. So we can certainly do that if we decide to move forward with it. Also, the board at this point is deciding that an upper payment limit can be an appropriate tool to address the drivers that we've identified. Also, same general methodology for implementing. So we plan to implement it in a way to minimize adverse outcomes and minimize the risk of unintended consequences. Again, this drug does have a high proportion of out-of-pocket costs compared to the system net costs. Next slide. This drug does, and then obviously very high spending, as we'll show on the next slide, so that exceeds the administrative costs. Also, we mentioned the generics, which will be coming to market in 2027, but that doesn't mean that there's going to be 9 or more at that point. We do need to make sure that any UPL does not impact statutory or regulatory amounts. And again, going back to that same issue, Jardiance does have a maximum fair price, and based on the regulations that we've implemented for ourselves, that does set a floor on what your upper payment limit could be. So just that's worth taking into account. And again, that will have implications in terms of potential savings for the policy for these 2 drugs. All right, next slide. Here are the amounts, again, pulling directly from the dossier, the amounts that could be impacted by the upper payment limit. So this is for state and local government. And then if you go to the next slide, Christina, this is gross spend for Medicaid. And that takes us to our final slide. So we can spend more time discussing the upper payment limits, but if you go to the next slide, Christina, our final ask from the board is guidance and direction from the board concerning which, if any, of the policies identified in the presentation should be further developed for board's consideration. For all the non-UPL policies, they would ultimately, we'll flesh out the details that the board asked for, but would ultimately be put forth before the board as a resolution that you can vote on in an upcoming meeting. That can only be done after you finalize your cost review study report. For the upper payment limits, the immediate next step would be for the staff to publish a framework, i.e., here's how we recommend the board come up with an upper payment limit number. And then we can flesh out some of the details that the board was asking about in terms of potential savings, potential implications, things like that. So that would be the next step, and that would come before the board for your approval, is the framework or the methodology for how we would go about setting the UPL.
Andy, along the lines of what we've all talked about, Barry and Jerry, all of us, for the upper payment limit and for the cost analysis and savings, if you're going to have to go out of house, do you have someone in mind already, or do you have a cost?
I would have to get back to you on that. We do have a few resources that we've gone to in the past, so it is a standardized process, but any procurement that we do kind of has a timeline associated with it. I can think of a couple ways to manage that. I think we can certainly do it in-house. As I'll talk about in our administrative update, we do hope to have our quantitative policy analyst onboarded in the near future, and this can be a project for them. So there's not much that out of house folks would be able to do that we can't do in house, but we can provide that cost to you.
Another question for me, before we get into, I guess, the meat of the discussion would be, is the staff considering these parallel workflows or potentially competing workflows in terms of UPL, non-UPL?
We would call them parallel, and I don't think it would pull staff resources away from one or the other. I don't think it would change the amount of work that we can do on either of these policies. And then nothing on either of these policies can happen until the cost review report is finalized and published. So all three of those are going to be moving kind of at the same time. So I would expect you to see a series of documents published, and I'll go over this during the administrative updates, for public comment, all to be ready at an upcoming meeting where you can approve theoretically all of these different documents at the same time. So, but I don't think they're competing resources at this point. We are managing across the 6 drugs that we're looking at. We are being very thoughtful about how we allocate resources across those 6 drugs. Yeah.
So Andy, I totally get that. Hopefully we can do all of them simultaneously, but if you have to make a choice, I would go with the UPLs. Assuming we decide to vote for it, I would go with them first.
Okay.
Dr. York,
Yes.
this is your Assistant Attorney General. I just wanted to answer one of the questions that a board member had raised about non-UPL policy 4. There had been some questions about its feasibility, and there had been some discussion about other states. And I did want to flag for the board that this past May, Colorado, in fact, adopted legislation that delinks PBM compensation from drug list prices, requiring PBMs to be paid flat fees instead of being compensated based on the rebate amounts or the drug costs. That legislation goes into effect January 1st of 2027.
Thank you.
So let me recap, kind of separate these two. Is the board okay with, in theory, moving forward on the non-UPL on, again, the WAC inflation penalty, the patient navigator, and the PBM pricing delink, in theory?
Yes.
I would be okay with it the way we've talked about how those 3 would be handled, not exactly all the same, right, in terms of staff engagement.
Right.
Well,
But
sort
I
of in that order.
Exactly.
In terms
I
of
agree with you.
priority.
Yeah, I would say the same.
Okay. Then if we're okay there, I'm assuming, Andy, you that's all you need for that, correct?
Yes, staff can put resources to those 3 policies.
And then we can move to the UPL issue, right? Whether I don't think we have to take a vote. We can just have our conversation here. Does the majority of the board want to move forward with the guidance of the staff on the UPL for both company drugs?
So I think, given that we need some more information and that will be coming, I would be in favor of moving forward with this process and, making sure that we get additional information.
Yeah, especially, with an idea of savings that could be realized.
Yeah, I'd be very much in favor of a process that has us, proactively gathering information that'll be helpful to us in terms of quantitative information, and then thinking about, what entity could help us with that or help the staff gather that information, because I think that there's certainly more detail than we need that we need to be able to make a decision than we have.
Okay. Andy, do you need anything else other than that?
I may check with staff and see if we need it. I think I
Is
think
that
we have
clear
what we
enough
need.
direction?
Yeah, in that we will be spending resources to create the next step, which is to propose a framework and methodology to the board. So this will be published for public feedback and then brought to the board. I think you probably would vote on that or give us guidance on it. So what that would look like is we would have our staff recommendation on how to come up with a UPL. And then board lets us know you should move forward with that or go a different direction. So that would be in an upcoming meeting.
And Andy, so that discussion on how to come up with a UPL includes the evidence requirements?
I think so.
Evidence
And then
requirements?
we've heard very clearly that you're also looking for like a savings estimate or the potential impact of a UPL on the framework, based on the framework that we would recommend. So we will do everything we can to get that information.
Yeah, I mean, I think it's like anything we do, it has to be scored, Andy. I mean, at least for me, it does. I'm not in favor of moving forward if it's not scored.
Yep. Understood. Yeah, no, we appreciate that. I think staff completely agrees. Yeah, and there's an easy scoring that I think you generally see publicly. Like, I think we could score it based on these gross numbers that we see, but I think staff is most concerned about the net price, and our definition of the UPL to the program is reducing that net cost to the eligible entities, and that's a much tougher lift than what we had expected. So.
Yeah, and
Just getting access
also
to the data.
there's lots of different entities that we're talking about.
That's right.
We're talking about people in incarceration. We're talking
Yep.
about different counties. We're talking about a whole variety of different things. So it might not be savings for one group, but it would be a savings for another group.
I think that's right. Okay.
Okay.
Great. Well, thank you for the discussion. And I think we have our marching orders.
So let me just ask the board one more time. I mean, is everyone okay with what we've just discussed and where we're moving? Are there any other questions or issues, comments?
I am looking forward to it.
Okay. Andy, I think it's pretty obvious. In order for you to move forward, in my opinion, you have to get these staff members on board.
Yes.
It's just imperative. So again, whatever we need to do, just because you're not going to be able to go out with any procurement under 2 years in Maryland, or a year and a half or whatever of any size to be able to do it out there. It's got to be done in-house.
Yes. Understood. And we have a lot of great talent in Maryland, so we're excited about that. I can provide an update during our administrative update.
All right. You want to just give a quick update on the lease? We'll be looking to approve it, but tell them what we've kind of negotiated so far in general. And
yeah. So the reason we put this on the agenda is our lease is up in February of 2026. So this is about the time where we start finalizing plans for location. I think staff is tentatively going to propose staying in the same location. So we have updated numbers. We'll be providing a report to the board and bringing the lease terms to the board for approval in an upcoming meeting before the February expiration.
And
Great.
you have enough space currently for all the people that you will be hiring?
We don't have anybody on board.
No, but what we do, hopefully, I'm always positive that we will have somebody there.
We have plenty of space. We have
Okay.
plenty.
Yeah, when we were reviewing with DGS,
We don't have anyone in the office 5 days a week, so we have plenty.
DGS also did confirm that any modifications could be made to fit additional staff, so we have flexibility there. Yep. Great. And then with that, I can move to our administrative update. I think Lise, great. So a couple things. One, again, just wanted to reiterate that we're very excited for our new board member, Dr. Georges Benjamin, and wanted to reiterate our thanks to Dr. Joe Levy for his amazing service. Just wanted to provide an update on staffing, which Chair Mitchell had mentioned. We had a posting for our quantitative data analyst, I think it was in May. We've been continuing to send offer letters that have not been accepted. So we are continuing to work our way down the list. We did have a number of eligible candidates. So I think we hope to have this position filled as soon as possible. Hopefully by our next meeting, we'll have a great update on new staff. And then we do have an administrative specialist pin that is currently open as well. We're exploring if we wanted to reclass that, but we're going to post as is. So we're planning to post hopefully this week. It's going to have a 2-week opening. So we'll be notifying on our website and publicizing as widely as possible. Looking for a great candidate to be an administrative specialist for us. Other updates. So again, just going back to the next step of the presentation. So just wanted to give you an update on some of the work that's happening. For as we just discussed today, the immediate next steps is for us to publish a draft report of the cost review study, preliminary determination of the cost review study. That basically is the draft version for public comment. I would expect that to be published in the foreseeable future. And then for the non-UPL policies, those again would be done through potentially resolution for an upcoming board meeting. And then for the upper payment limits, based on the board feedback today, our next step is for staff to publish a methodology or framework for public comment. So we will send notifications out to the public, post on our website, send notifications out with comment periods and things like that. So that can be presented to the board in an upcoming board meeting. And then the final thing is we do have the 4 other cost review studies ongoing. I just wanted to provide a quick status update on all of those. We published the dossiers for 2 more drugs, the draft dossiers, that was Ozempic and Trulicity, and we received comments on those dossiers. I would expect us to publish the final versions of those dossiers for the board to take action on in the very near future. I think they can be published certainly before your next meeting. It's up to the board on if you want to address those in your upcoming meeting. So we'll talk about how to fit them on the agenda, but those dossiers are ready for board review and will be shared with the board. The last 2 drugs, Skyrizi and Dupixent, we're finalizing the request for information process. And then that information will then feed into the dossiers. So those draft dossiers for public comment should be published by the end of this year for public comment, and then we'll finalize for the board to consider. So that's where we are on everything. A lot to cover between now and the end of the year.
So Andy, let me go back to something you said, because you've said it a couple times now. And if Michelle needs to weigh in, that's fine. You've talked about that you need to do resolutions for, I guess, the 3 things that we talked about outside of the UPLs. Why do we feel like we have to do resolutions?
Yeah, that's a great question. There's final action that the board would need to take to endorse these recommendations, basically. So it may not need to be a resolution. That's correct.
Why? I mean, it's an open discussion about an issue. Why does the board have to vote on it if the board's in agreement to tell you that this is something that we want you to do? I mean, I guess is this a legal thing that we're being told we have to do, or what?
No, I can take it back to the staff. I mean, another option could be to publish them in their final report, and then your approval of the final report is kind of the endorsement of those policies. I think what we're looking for is basically a formal endorsement from the board that can be passed on to the entities that would actually, or formal recommendation from the board. So whether or not that's a resolution or a different format, we can make sure we take that back to you. So I apologize for the confusion there.
No, I'm just trying to understand it, because when you talk about resolutions, then your time and Michelle's time and Christine, it takes you guys a long time to do a resolution. I don't want to waste any time on resolutions for what I think the board is just directing you to do.
Yeah. Okay.
And why we would need to put it in a resolution, I don't know.
Understood. Yeah, I think that's a loose term that I've been using in terms of like a formal recommendation from the board, but we'll make sure we minimize staff time and resources for that part of the process.
Okay.
Yeah.
Great. Thanks. Just a couple things. Christina, are we, for the November meeting, I know we talked at the last staff meeting, have you cleared, is the room available for 11/17?
Both rooms are available for 11/17 if you need them.
Okay, So I think we haven't made 100%, but I think we're probably leaning toward in person. It's the week before the holidays, so we're trying to maybe lean in person on November 17th meeting, which would be in Annapolis at our normal room. So I'll get with Christina and before we make a final and send out a notice to everyone. Again, we'll send the resolution from on the board's behalf to Dr. Levy. Again, hopefully everyone has his email and can send Joe a little note of thanks on their own. Again, I welcome George's Benjamin. I think the board is going to find him when he's got the time to come in, very engaging, very thoughtful, a lot of wisdom, just a great person to work with. And I think will bring a different perspective to the board from not only Maryland, but from a national perspective, which I think might help us as well. So again, I'm really happy that we finally got the appointment for the governor done. And with that, let me go around the room. Is there any other comments or questions? Steve, you have anything?
No, I'm good right now. This has been a very fruitful meeting.
Jerry?
So we have a lot that we're going to be doing with, a lot of drugs and whatever. So I think come next year, we should think whether or not we need to have it every 2 months or every month. But because, lots of things are going to be happening with lots of different drugs at different times. So something to consider for next year.
Okay. And along those lines, Christina and Andy sent out to all of you that we had worked through the list of the meetings for next year. I would encourage you to look at that and get back to them if there are any issues. We tried to go through the calendar, all of us, to stay away from any conflicts. But if the three of you would please go through those dates and get back to Christina, that would be great. Let's see. How about a Barry? You have anything, Barry?
No, this was a great discussion and glad to see us moving forward on several of these. And just one point on the patient navigation is, to the extent we can, leverage organizations that are already doing a lot of this work. We're not a patient organization, but we've worked and I think heard from many. And I would just want to encourage us to leverage infrastructure already in place for our state and try to increase that reach as much as we can, because that is a great opportunity to assist patients.
Great point. Well taken. With that, Andy, do you have anything else?
Van, can I just say that the next PDAS meeting is scheduled for October 27th at 2
Oh, I'm
p.m.
sorry. Yep.
Thank you.
Is that virtual?
Yes.
Okay. Time 2 o'clock?
Yes.
Great.
Thank you.
Andy?
Nothing else from staff. Thank you.
Okay. Nothing else. Thank everyone for their time. It's probably not good for the chair to have a board meeting the Monday after the Ryder Cup, because he's still in a very bad mood after watching the debacle for 3 days. So I apologize to you if I had an edge. It'll improve next month. But let me have a motion for adjournment.
So moved.
Second.
Thank you, Stephen. We stand adjourned until November 17th. Thank you very much.
Thank you.
Thank you.
Bye-bye.